Hi everyone, very good evening to all of you guys. Very warm welcome to all of you. Myself, Dr. Vaibhav Jain, and today we will be studying the subject of physiology, guys. Okay, do let me know in the chat section whether I'm clearly audible and visible so that we can proceed with the session, guys. Let me know, guys. In today's session, we are going to cover up the most important topics that has been asked in your examination from this particular subject. Okay, we will be studying about all the things that are potentially asked in your examination from this particular subject, right? Okay, Ashik, I can see now that everything is fine. Okay, so what is the scheme of our class today? Guys, we are going to see multiple topics. Okay, I have incorporated multiple topics that has been asked in your examinations, and we will be discussing about every options, all those things related to these topics, right? So yeah, okay, okay. So without any further delay, I think we should start. We should start with the quote of the day, and the quote of the day is whatever you are, be a good one, guys. Okay. I know it's been only 20 days left for your examination, for your FMG examination. I know you guys must be anxious, multiple things are going on in your mind, but the only thing that you should be remembering, keep hustling, keep doing your hard work. It's just 20 days. After this, that life will be different, guys. Okay, so just give whatever you are having and keep pushing yourself. Okay, only 20 days you have to do good things, then life will be settled. You will be on the other side of the fence, right? So without any further delay, let's the class will be not too much long. We will try to cover up everything. Even if you have not studied physiology, this class would be good enough to get even 10 questions are coming, you will be able to solve 7 to 8 questions directly from this class. Okay, I would try to make it as clear and concise for you. Okay, so we are having 40 questions. We will be doing 40 questions. In those 40 questions, I will try to cover most of the topics. Okay, 40 to 50 topics will be covered. Yeah, that would be enough. Okay, so बाकी सब ठीक. Let's start with the topic and let's start with the question number one. I just want you guys to be interactive with me. Okay, you guys will be answering and we will be learning new things here, right? So please try to be interactive and we will be learning things. Okay, so the question number one says a 7-year-old boy presented to OPD. Okay, so whenever I'm going to teach you how to solve the question. So whenever a patient is coming to you, bache, what you need to do, what you need to understand from the question, there are some things that are written in the question itself. There are some keywords. Okay, so what they have given, there is a 7-year-old boy presented to OPD. Okay, 7-year-old boy presented to OPD. His mother is stating that he is having difficulty in rising from the floor. You need to identify the keyword. So what is the keyword first? The patient is having difficulty in rising from the floor, right? His calves are hypertrophied. Okay, second clue that they have given you is calf hypertrophy. And tell me guys in the chat section, what is the diagnosis? Calves hypertrophy are generally associated with what? That is a very important clue that they have given you. Whenever there is a calf hypertrophy, always think in the terms of muscle dystrophies. Muscle dystrophies, right? There are multiple muscle dystrophies. Whenever this symptom is given, you need to think about muscle dystrophy. Okay, third thing, which of the following substance defect or deficiency is the cause of the patient's condition? What can be the answer, guys? Oh, great. I'm getting good answers. That is C, C, C. Most of you are going with the dystrophin. Okay, then tell me why not the answer is A. And what do you know about A? First of all, a single habit that I want you, all of you to have is simple, that you have to eliminate the options, guys. Even if you are preparing for FMG examination, you have to remove the options. Okay, you need to eliminate the option. That is how you are going to get the best answer. Okay, because sometimes you know what happens, it is basically there are four options and answer is also in front of you. You need to learn the elimination. So first of all, dynein cannot be the answer. Sir, what is the function of dynein? Tell me guys, what is the function of dynein? Tell me in the chat section, what is the function of dynein? Sir, dynein is responsible for reverse axonal transport. Dynein is responsible for first thing, reverse axonal transport. Now you will be asking, sir, what is reverse axonal transport? Reverse axonal, what is the meaning of axon? You will be looking at neurons. So this is your cell body. neuron will be having this structure, that is axon, and then there will be some, what is this, synapse, not dendrites. Dendrites will be here, right? Dendrites will be here. This is your axon, right? This is your axon. Now forward axonal transport means what? Forward means information is going from above downward, okay, from the cell body to the synapse. This is your forward axonal transport, okay. And reverse axonal transport means the information is coming from the synapse to the cell body. That is your reverse axonal transport, okay. So who is responsible for reverse axonal transport? That is your dynein. That is your dynein. So dynein will be responsible for reverse axonal transport. And can anyone tell me what are the two most important diseases that you study in microbiology, guys? What are the two important diseases that follow this particular pathway? And this was the question that they have asked you. So first one, let me tell you, first one is your tetanus. Okay, first one is your tetanus and second one is your rabies, guys. Both of them are 100% fatal disease. Okay, if someone is having tetanus or rabies, that means he is going to die. Rabies is due to which virus? Please try to answer in the comment section. We are integrating multiple subjects. Okay, this session will be very fruitful for all of you, right? So please try to integrate multiple subjects. Please try to be interactive. Try to answer, right? Okay, so tell me, what is the causative agent for rabies and what is the causative agent for tetanus? Okay, so the causative agent for rabies will be not rabies virus, that is your Lissa virus. Lissa virus. Lissa virus is the causative agent for rabies. Okay, why it is important, sir? Remember one thing, whenever you are having a dog bite, you know what happens? Those bodies you will be finding in the hippocampus. There, these are your negri bodies. How they are reaching to hippocampus? Because they are going through this particular reverse axonal transport. Okay, so the virus will be going from this, from below to upward, right? So that is due to reverse axonal transport. Second one is your tetanus. Tetanus is due to Clostridium tetani. Very good. That is due to Clostridium tetani. Very good, Sana. So that is due to Clostridium tetani. Okay, Clostridium tetani. Now, what other function of dynein do you know? Dynein is also helpful in the movements of cilia, guys. Very important question coming. Dynein is also important for ciliary movement, and the movement of cilia will always be unidirectional. Unidirectional means एक ही direction में movement होगा, right? So ciliary movement is also due to dynein. Okay, now what will happen? For example, you are having ciliary movement in the sinuses, right? So whatever things, for example, you are driving a bike, you are going outside, you know what happens? Some dirt particle will go inside, right? After some times you will be coughing all those things, right? So that is with the help of cilia, right? The movement of in the fallopian tube, for example, these are your fallopian tube. The egg will be coming, fimbria will pick up the egg and it will be transporting the egg in the forward direction. Okay, so ciliary movement is also due to dynein. Okay, and if there is defect of dynein, very good, Rohit, that is your, if there is defect of dynein or defect of this ciliary proteins, what will happen? There is a syndrome known as Carter-Jenner syndrome. Very important question from physiology. That is your Carter-Jenner syndrome, guys. Carter-Jenner syndrome. Can anyone tell me what is the triad for Carter-Jenner syndrome? क्या क्या होगा Carter-Jenner syndrome में? What are the things you will be encountering in Carter-Jenner syndrome? Just remember, those who cannot do MBBS, those people, some people are doing some BDS, right? So just remember BDS. Okay, so first one is your bronchiectasis. Second one is your dextrocardia. Dextrocardia means क्या हुआ? हार्ट आपका इधर की साइड आ गया, राइट साइड में आ गया. As for sinusitis, you must have studied about sinusitis till now, right? Very good. That is your sinusitis. Yes, we can also call it situs inversus. Okay, and you will also be finding infertility in some patients. Why? Because egg is not moving. Why? Because there is no cilia, no movement of egg. There will be no fertilization, there will be no baby, right? So for an infertility patient, obstetrician infertility patient, you need to check for this particular syndrome also. That is your Carter-Jenner syndrome. Understood, guys? Okay, next thing is your second option. Okay, so two important points you need to remember about dynein. If there is mutation of dynein, what will happen? First function of dynein will be reverse axonal transport. Okay, reverse axonal transport. Two diseases important: tetanus and rabies. Rabies is due to Lissa virus. Okay, tetanus is due to Clostridium tetani. It is a proteolytic species. Okay, this is your axon, what we have seen. This is the movement of cilia, right? Carter-Jenner syndrome is the defect. And what is the triad? Triad would be your bronchiectasis, dextrocardia, and sinusitis. Along with that, there can be infertility also. Okay, did you understand? Second option is your desmin. Tell me about desmin, sir. What is the function of desmin? Desmin is a try to answer, guys. What is desmin? Try to answer. V, Rohit, Nidhi. So desmin is a what kind of a protein? It is a marker. It is a marker for what? Answer me, guys. It is a marker for sarcoma, guys. No, that is not for the Z line. It is a marker for sarcoma. It is an intermediate filament, right? You have studied about some intermediate filament. For example, keratin. Keratin is a marker for carcinoma. Whatever information I am telling you, you can write it down for yourself in your notes itself, right? So keratin is the marker for carcinoma. Increased keratin means increased there can be epithelial origin tumor, that can be carcinoma. Okay, desmin is increased, that means there can be sarcoma. Okay, vimentin is there, gfap is there, lamin is also there, right? So they are indicating different type of cancers in the body. Okay, we can utilize them, right? So desmin is a marker for sarcoma. So what is sarcoma? Sarcoma is a cancer of mesenchymal origin. Okay, it is a cancer of mesenchymal origin. Okay, next one, dystrophin. You already know about dystrophin. So dystrophin, just remember one more thing, it is the largest gene. It is the largest gene and it is present on chromosome number which? It is present on chromosome number 1, guys. It is present on chromosome number 1. Okay, the mutation of this dystrophin, it is basically a structural protein providing support to the muscle. Okay, so it is basically a structural protein present on chromosome number 1. Now what will happen? There can be two possibilities if there is mutation. If there is complete mutation of dystrophin, there will be Duchenne muscular dystrophy. There will be Duchenne muscular dystrophy. If there is a partial loss, of dystrophin, there will be Baker's muscular dystrophy. Okay, based on the lethality, there will be two divisions. Okay, Baker's people will live longer, Duchenne will die earlier. Okay, so we are having Duchenne muscular dystrophy, Baker's muscular dystrophy. One important sign that you will see in this particular disease, try to answer. One important sign that you will see in this particular disease, that means when the patient, when you are going to see this kind of patient, you are sitting in a OPD, a patient is coming to you, a boy is coming to you, what you will say, please sit down and try to get up. Okay, so when the patient is again sitting up, what will happen? You will be looking at a particular posture, he will be using support of his body, right? And that sign is known as Gower sign. That patient will be standing up like that, he will be using the support, right? He will be standing like that, and this particular sign is known as which sign, guys? This particular sign is known as Gower sign. Very good, very good. Not tower sign, that is Gower sign. Okay, Gower sign. So when the patient is trying to stand up, that is your Gower sign. That is your Gower sign. If there is complete loss of dystrophin protein, if there is complete loss, there will be Duchenne muscular dystrophy. If there is partial loss, there is Baker's muscular dystrophy. Last option we are having is lamin. If there is mutation of lamin, what will happen, guys? Yes, it can be a frame shift. Okay, if there is mutation of lamin, what will happen? There will be a disease that is known as progeria, guys. Progeria. There will be a disease known as progeria. You must have seen the movie Pa. In movie Pa, what is happening? The Amitabh Bachchan, he is having progeria. That is due to mutation of lamin, right? That is due to mutation of lamin. So answer for the question number 1 will be C. Answer for the question number 1 will be C. Understood, guys? Is that clear? Are you guys understanding? Okay. So whenever you will, what you have learned till now, dynein mutation, there can be Carter-Jenner syndrome. Desmin is a marker for sarcoma. Dystrophin is the largest gene causing Duchenne or Baker's muscular dystrophy. And lamin, if there is mutation, that would lead to progeria. Lamin is also coming under intermediate filaments, right? Now, coming out to question number 2, please try to answer. Substances and the types of transport across the membrane are given below. Try to choose the incorrect combination. So whenever you will see such type of question, all except, incorrect, this type of questions, there is a high probability that we mark it wrong. So please try to be more attentive. Please try to be more active while solving this type of questions. Okay, so please try to answer what could be the answer for question number 2, guys. What could be the answer? Bachcho, bolo. Try to eliminate the option. First, option number one. Option number one, oxygen via simple diffusion. Is that right? Is that right? Oxygen via simple diffusion, guys. Yes, oxygen, we don't need any kind of energy, right? Oxygen, we don't need any kind of energy. First of all, try to understand what the question wants to know. Okay, question wants to know the incorrect combination. You need to identify the incorrect combination here, right? Question option number A, that is oxygen is simple diffusion, that is a true option. For inspiring, we don't utilize any kind of energy. Here I'm getting some mixed answers. No problem, guys. If you are making mistakes here, that is completely okay. That is completely okay. But don't repeat these mistakes in your examination. This question has particularly asked approximately 7 to 8 times. You can see in your previous year papers, you will be finding this particular question has been asked 7 to 8 times. Okay. So look here, guys. What are the things that you need to remember? Oxygen is simple diffusion. Simple diffusion means does not use any energy. Fructose is facilitated diffusion. What do you think, guys? Fructose is a facilitated diffusion or not? Fructose with the help of which glut? Glut 5. Just remember F for 5, F for fructose. So glut 5 is the utilized for fructose absorption. Okay, sodium potassium 2 chloride, that is a secondary active transport. Is that right? Yes sir, this is right because it is a co-transporter. I would be telling you the trick how to remember this. Okay, next one is your aquaporin. Aquaporin is a primary active transport. No, it is not. It is a false statement. Right, now we will see why it is a false statement. Try to understand this. Okay, so we are looking at different types of different types of transport. Okay, so we are having this particular cell will be having cell membrane, right? Cell will be having cell membrane or cell wall. Cell wall is absent in humans, right? We don't have cell wall. Cell wall is present in bacteria. We are using cell wall synthesis inhibitors. Name some drugs, some cell wall synthesis inhibitors in the chat section. Till then I'm telling you about the transport. Okay, so whatever things are coming inside, that is to and fro movement, whatever things are coming inside a cell and whatever things are going outside a cell with the help of this particular transport, and this is known as cell membrane transport. Okay, we are having two things. One is ATP dependent transport, another one is ATP independent. Independent matlab kya hua? It will not utilize energy, it will not utilize ATP. That is known as passive transport. What is that known as? That is known as passive transport. There is no ATP utilization. First thing understood. Second thing, what are the different things that are coming here? First thing is your simple diffusion. This is a particular question, multiple times they have asked you. Please try to be attentive. Okay, simple diffusion, your example will be osmosis. You know, things are going from its higher concentration to lower concentration. That is simple osmosis, does not require any kind of ATP, right? Oxygen is more in the environment, less in the lungs, so oxygen will be coming into lungs, right? Carbon dioxide is more in the lungs as compared to environment. Carbon dioxide will be going out in the lungs. That is simple diffusion. Now what will happen? Try to look here. We are having osmosis also. Osmosis, it can be of three types: isotonic, hypotonic, hypertonic. What is the meaning? Solutes and solvent are equal. Like for example, there is a glass of water, it will be having some water and some salt, that is isotonic. If the salt is more, that is known as hypertonic solution. Solute is more, solute means salt. If salt is more, that is hypertonic. If salt is less, that is known as hypotonic solution. Okay, not so important. Look here, this one is the important one, facilitated diffusion. We are having two types of diffusion here. First thing is your hydrophilic, second one is your hydrophobic. Okay, hydrophilic will be requiring channel proteins. Okay, hydrophilic means what? They are loving water, right? And hydrophobic means what? They are repelling the water. So we are having particular thing for them, and that is the question they have asked you. That is your carrier protein. Even if you don't remember anything, just try to remember this particular statement that I am giving you. Glut and aquaporins are coming under facilitated diffusion. Okay, glut and aquaporins are coming under facilitated diffusion, and they are a type of carrier protein. This is the information that you should be remembering. Okay, that you should be mixing all the time. So you have to remember this particular thing. Okay, second one is your active transport. This one is done. For passive transport, two things you have to remember. First thing is your simple diffusion following fixed flow. Okay, second one is your facilitated diffusion. Two types, one is channel, second is carrier. Okay, in carrier we are having glut and aquaporins. Glut and aquaporins, very important information, guys. Okay, second we are having active transport. Active transport means what, sir? It will be utilizing some kind of energies, right? It can be vesicular transport, it can be with the help of pump. Okay, so vesicular में क्या होगा बच्चों? Try to look here. We are having two things. Vesicular transport, we are having two things. One is endocytosis. If something is coming inside, that is endocytosis. This is the second question they have asked you. What is the protein that are regulating endocytosis? Okay, and second thing they can do is exocytosis. Whatever things are there, they will be throwing out. That is your exocytosis. Okay, so just remember the proteins for endocytosis and exocytosis. The protein for endocytosis will be Clathrin and Miguelin. Wherever you are, try to speak. These are the previous year question that has been asked. Endocytosis proteins will be Clathrin and Miguelin. Okay, endocytosis means what? Look here. Let me show you. This is your endocytosis. This substance is here. What is happening? They are engulfing the substance and they are making something a vesicle. That is known as endocytosis. Here, what is happening? There is a vesicle. It will be going out and it will be releasing its substance. That is your exocytosis. That is your exocytosis. Okay, this is your endocytosis. Okay, look here. This one is your, try to understand this. We are having Clathrin, we are having Miguelin. Apart from that, if the material is solid, whatever things they are engulfing, if it is solid, that is known as phagocytosis. That is known as phagocytosis. If the material is liquid, whatever they are engulfing, if the material is liquid, that is known as pinocytosis. Just remember, just like pina, what we are drinking, that is liquid, right? So if there is a liquid, that is pinocytosis. Okay, and we are also having some protein binding to the ligand, that is receptor mediated endocytosis. Not so important. You have to remember these two important points. Okay, second one is your something is getting out, that is your exocytosis. And exocytosis is via which proteins? Snare proteins. Okay, snare proteins. Till now you have remembered these two important things. Now let's talk about the pumps. Okay, this is the most important part where you are getting questions, and this particular slide has been asked in your examination. You can see in INI SAT FMG examination multiple times they have asked this question. So try to answer this. Okay, so we are having primary active transport, we are also having secondary active transport. Two types of transport we are having. We are having primary active, we are having secondary active transport. Primary active, what is happening? The energy they are utilizing the energy for the same pump, for the same molecule. Okay, both of them are utilizing energy for the same pump. Okay, for example, we are having proton pump, we are also having sodium potassium ATPase pump. Okay, second one is your secondary active transport. Just try to remember a single point that I am telling you. If you are looking at the question, they are not utilizing energy from this for the same pump, they are giving each other. But you just have to remember, if in the question they have written symport, if they have written any kind of antiport, co-transporter, okay, exchanger, anything like that, symport, antiport, co-transporter, exchanger, your answer would always be secondary active transport. Secondary active transport. Wherever you will see two molecules are going here and there, your answer would be this one, secondary active transport. So whenever you see any kind of symport, any kind of antiport, any kind of co-transporter, exchanger, for example, you see sodium iodide symport. So two things are going in the same direction, that is your sodium iodide symport, and that is responsible for what? That is a secondary active transport. Okay, now onwards, whenever I'm talking about any pump, I would be asking you, is it primary active, is it secondary active, is it facilitated diffusion? Okay, second thing, we are having sodium glucose like transporter, SCLT, right? We are also having sodium potassium potassium 2 chloride pump, they are present in your kidney, right? So all these are the examples of secondary active transport. Clear hai? Right? If single thing is going, that is your uniport, two things are going in the same direction, that is your symport, and two things are going to and fro, that is your antiport. Okay, so this is the most important slide. Let's recap what we have seen. Yeah, that is clethrine, not calcium. Okay, so what we have studied, look here, what we are having cell transport. Okay, so two things can happen, it either it can be passive transport, either it can be active transport. Passive mein kya hoga, what will happen? Passive, it can be due to diffusion, it can be due to facilitated diffusion, right? Facilitated mein kya yaad rakhna hai, what you have to remember, you have to remember about the glut. Okay, glut and aquaporin, they are what type of protein? They are carrier protein. Okay, here you have to remember, in the active transport, vesicular transport can be there, endocytosis, exocytosis. Endocytosis with the help of clathrine and myelin, exocytosis with the help of snare protein. If the substance is solid, what do we call it? Try to answer. Substance is solid, that is known as phagocytosis. Substance is liquid, that is known as pinocytosis. Okay, so that is what is important here, right? Okay, let's move on to next. Second thing is your about the pumps. If they are utilizing same pump, that is your primary active transport. If they are utilizing different pump, that is your secondary active transport. Any kind of symport, antiport, co-transport or exchanger. Okay, all these things you will be looking at in the question. You will be marking the option secondary active transport. Is that clear, guys? Do let me know in the chat box also that you guys are understanding. So what would be the answer here? Now try to answer. Sodium potassium 2 chloride is a type of co-transporter. Okay, aquaporin will be coming under what? Now please try to answer. Aquaporin and glut. Remember, I have told you glut and aquaporin, both of them are example of facilitated diffusion. Okay, facilitated diffusion. So this cannot be the answer. Okay, so the answer would be D. Answer would be D. Okay, answer would be D. Okay, now try to solve this particular question. What is the neurotransmitter that is released from parasympathetic nervous system? I think most of you will get this one right. I really hope. Try to answer this. Cypriya, Sahana, very good. Okay, try to answer this one. Third one. What would be the neurotransmitter that is responsible, that is released from parasympathetic nervous system? First of all, parasympathetic nervous system is also known as, try to answer, guys, waiting for your answers. D, very good. Pradeep, Sai, Priya. So, Rinkesh, Shahana, Rohit, Anu. Okay, why the answer cannot be A, B or C? Try to answer. A is epinephrine. Epinephrine will be working on which receptor? Please try to answer. Epinephrine will be working on which receptor? The answer will be D. Epinephrine will be working on alpha 1, alpha 2, beta 1 and beta 2 receptors. Okay. E for epinephrine, also known as adrenaline, and adrenaline is working on all the receptor. A for adrenaline, A for all the receptors. Okay, norepinephrine will be working on alpha 1, alpha 2 and beta 1. Okay, dopamine, try to answer the doses of dopamine, guys. Dopamine will be working on what? It will be working on D1 receptor. Okay, if we are giving in the doses of 0 to 2 mcg per kg, if we are giving 0 to 2, it will be working on D1 receptor, causing what? Diuresis. Okay, if we are giving somewhere in between matlab beach mein, if we are giving beach mein, that is 2 to 10 mcg per kg, that would be working on beta 1 receptors. Okay, beta 1 receptor. And if we are giving more than 10 mcg per kg, what will happen? It will be activating your alpha receptors also. Okay, so dopamine will be having dose dependent doses, and this is the question they have asked you. Okay, so this you have to remember. Yes, we can use this for other purpose also. Okay, so let's discuss a little about this one. You guys have already answered. Let's discuss a little bit about this one. So basically, nervous system is further divided into two parts. One is central nervous system, another one is peripheral nervous system. Okay, central में क्या आएगा? Central में we are having brain, we are having spinal cord. So we are having brain as spinal cord. Peripheral Peripheral, we are having two system. One is most important, that is autonomic nervous system. Autonomic will be having two part. One is parasympathetic, another one is sympathetic. Parasympathetic means rest and digest system, and sympathetic means that is your fight or flight system. Okay, fight or flight system. Let me tell you all the receptors. Okay, let's talk a little about parasympathetic nervous system. So how do we remember parasympathetic nervous system? This is also known as, you have already told me the neurotransmitter would be acetylcholine. So this is also known as cholinergic system. This is also known as cholinergic system. Confuse nahi hona exam mein, right? I would be telling you the tricks how to utilize this particular set of information, right? So how do we remember what will happen? What is the use of this particular system? For example, those people who are smoking, right? Those people who are smoking, you know what happens when a person is smoking? क्या होता है जब सुट्टा सुट्टा लगाते हो, सुट्टा पीते हो, तो क्या होता है? What are the things that are happening to your body? Smoking will be activating what? It will be having nicotine, right? Parasympathetic nervous system will be having two types of receptor. One is muscarinic receptor, another one is nicotinic receptor. Okay, so muscarinic receptor कौन सा होगा? We are having M1, we are having M3, we are having sir M5. Try to remember as it is I am telling you. Okay, M1, M3, and then we are having M5. We are also having M2 and M4 receptor. Okay, just remember simple thing. M1, M3, M5, they will be causing contraction. Wherever they are, they will be causing contraction because there is a GQ subunit. M2 and M4 will be causing relaxation. If you understand this particular concept, your life will be easy. Autonomic nervous system will be on tips. Okay, so look here guys, M1. So you need to remember from the body itself what will happen when you smoke. So M1 receptor will be present in your stomach, first thing. So those people who are smoking, you know what happens after smoking? There will be some kind of peristalsis, right? Those people are going for toilet in the morning, they are smoking before that, right? So they are having stomach receptor. Second thing, we are having receptors in the CNS. Okay, so those people who are studying in library, they are again and again going outside in the Gautam Nagar, right? So you must have seen all those things. Then you are having M3 receptors. M3 receptors will be present. Let's see one by one. From the eye itself, we are having M3 receptors in the eye. So what will happen? What will happen? Try to understand. After eye, we are having M3 receptor in the glands. That is your salivary gland. We are having salivary gland. Okay, then M3 receptor will be present in your bronchus. In your bronchus. Okay, then this M3 receptor will be present in your bladder. Okay, this one is also present in your GIT muscles. Okay, so it will be present at various places. Okay, M5 is present in your CNS again. Okay, now see what will happen when you smoke. When you smoke, what will happen? Your stomach will be having glands. Those glands will be contracted. What will happen if the glands are contracted? There will be increase of secretion. Now you know why the people are smoking, right? What the things are happening. In CNS, it will cause contraction. Contraction means what? It will increase acetylcholine. And whenever there is increase in the acetylcholine, your brain activity will increase. Okay, so there will be increase in cognition. Increase in cognition, right? Next thing, eye, what will happen? It will cause meiosis. It will be causing contraction. That is your meiosis. In salivary gland, those people who are chewing nicotine, whatever nicotine products they are using, what will happen? They will be spitting again and again. So that would be again contracted. Salivary gland contraction will be there, right? In bronchus, what will happen? These people will be having problem while respiration, right? They will be having, it will be causing bronchoconstriction. It will be causing bronchoconstriction. You know what happens to the bladder? The bladder will be contracted, leading to what? Urination, guys. Urination. All these information are very important. Okay, GIT muscle, it will be increasing what? Peristalsis movement. It will be increasing peristalsis. Due to contraction, what will happen, sir? There will be peristalsis. Okay, next, lastly, we are having again CNS. That would be causing again cognition. That would be increasing again cognition of the patient. Cognition means what? The patient will be thinking everything, right? Next, it will be causing relaxation on M2 and M4 receptor. You just need to remember M2 will be present in your cardiac muscles, in your heart. It will be present in your heart. Okay, and M2 will be having two things. M2, just remember two. it will be present on your SA node, it will be present on your AV node. Sir, SA node का function क्या होता है? Please let me know in the chat box what is the function of SA node. So I am telling you it will be causing relaxation. That means SA node will be relaxed. What will happen? Decrease in heart rate. Very, very important thing. SA node is always concerned with guys heart rate. जब भी SA node की बात करूँगा heart rate की बात करूँगा. Second thing is your AV node. Whenever I will talk about AV node, I will be talking about conduction system. Conduction system, guys. Okay, that would be conduction system. Okay, and whenever I will talk about muscles, then only I will be talking about contraction thing. Okay, three things. Your heart is all about three things. SA node is always about heart rate. It will be increasing heart rate, decreasing heart rate. Bradycardia, tachycardia. Low heart rate, bradycardia, more tachycardia. Okay. Second thing is conduction. That means current is coming from above chambers to below chamber. That is your conduction. That is via AV node. So what will happen? M2 receptor will decrease the heart rate and decrease the conduction. That is why what is happening? Those people who are anxious, they will be smoking. What is happening? There will be relative bradycardia that you will be seeing. You will be finding some kind of bradycardia. Apart from that, their conduction system will be low. Right now, how can you utilize this particular set of information? You can use multiple drugs that you have studied in your pharmacology. Right, if there is, you can remember there is M1 blocker. I am just giving you example. I really hope you have completed your pharmacology just for correlation purpose. Okay, so there is increased secretion. What you can do, you can use pyrinzapine or talinzapine, that is M1 blocker. Okay, that is decreasing the acid secretion. Second thing, it will be increasing cognition of the brain, parasympathetic. So we can use certain drugs, for example like scopolamine, or we can also use thiopentone. They will be decreasing, we will be blocked. Basically what we are using M1 blockers, right? M1 blockers will block this system, and what will happen? The opposite will happen, right? In eye there is meiosis. What will happen if I'm giving a drug that would be causing, like for example I'm using pilocarpine or some other drugs? What will happen? Atropine. What will happen? There will be dilation. Okay, there is salivary gland contraction. Okay, normally parasympathetic is doing salivary gland contraction. What I need to do to stop this? We can use certain drugs that can decrease the secretions. What is that? In anesthesia you guys are using that is your nothing but your glycopyrrolate. Glycopyrrolate is doing what? It will be decreasing secretions. All these drugs which are working opposite to these drugs, they are known as anticholinergic. Opposite to cholinergic is anticholinergic. Okay, bronchoconstriction is there. We can use theophylline, guys. Theophylline will cause what? It will be causing dilations. Okay, urination is not there. We can use neostigmine like drugs. Okay, peristalsis is not there. We can use dicyclomine. We can use meftal-spas. Multiple things we are using, right? For this particular purpose we are having, it will be decreasing your heart rate and conduction. What is that drug that we are using for this particular thing? That is, what is the drug of choice for bradycardia? Here we are having bradycardia with conduction block. What is the drug of choice for that? That is that atropine, guys. Atropine is the drug of choice, which is a anticholinergic drug that we are using for this particular thing, right? I think you are done with this. Is that fine? So that is your acetylcholine. Okay, we are having, let's talk about some sympathetic nervous system. Sympathetic, we are having two receptors, alpha and beta. Alpha 1, the function will be vasoconstriction. Okay, beta, we are having beta 1 and beta 2. Just remember guys, beta 1 will be having three receptors. Beta 1 will be working on three places in your heart. It will be working on SA node, it will be working on AV node, and it will be working on muscles. It will be activating your SA node, causing increase in heart rate. It will be activating your AV node, causing increase in conduction. It will be activating your muscles, causing increase in contraction. Okay, so all three things will be activated by beta 1 receptor. Okay, second, beta 1 is present on your kidney. In kidney, it will be causing increase in renin, which ultimately lead to increase in vasoconstriction and leading to increase in BP. Are you guys understanding this? Okay, I am just giving a quick recap. Yes, renin is coming from that JG cells. Okay, renin is coming from that JG cells, and renin will be making angiotensin type 2. Okay, and it will be having two receptor. Angiotensin type 2 will be having two receptor. One is on the blood vessels, and second receptor is present on your adrenal cortex. That would be leading to release of aldosterone, that would be leading to release of aldosterone that is present in your zona glomerulosa region. Okay, so these are the things that you should be knowing. Beta 2 will be causing bronchodilation. Apart from that, from pharma, two things I'm just telling you directly, not giving you explanation. That is two side effects. One is tremor. There will be two side effects. One is tremor and second one is your palpitations. Okay, so these are the side effects of beta 2 agonists. Okay, so this is a quick recap about the parasympathetic and sympathetic nervous system. If you guys are having any doubts, do let me know. I would be solving here itself, right? So what we have seen, parasympathetic, we also known as cholinergic system. Acetylcholine is the neurotransmitter. What are the things we need to remember? M1, M3, M5. As it is, just remember the function of smoking. What will happen when you smoke? Multiple things will happen in your body, right? In your stomach, your secretions will be increased. In CNS, the cognition will increase. Your eyes will be having some kind of meiosis. Salivary gland, that would be releasing more saliva, right? You will be spitting. Bronchus will be constricted. The patient will be having problem while smoking, right? Bladder will be contracted. Bowel movements will be contracted. You know what happens? The patient will go for defecation because of excessive movements of the GIT. That is, everything is well explained here, right? So these are the, yeah, these, yes, hypokalemia is also a symptom, right? So these are all the important points about this particular thing. M2 will be present on your heart, SA node and AV node. So when we will be studying about medicine, that is the important part that you should be knowing. Okay, so SA node will be causing decrease in heart rate and AV node will be causing decrease in conduction. Okay, and that would be leading to the symptoms, right? And the drug of choice for these two particular things that we will be finding in heart block also, that is bradycardia with AV block, the drug of choice will always be atropine. We are using atropine. Atropine is also drug of choice for which poisoning? Organophosphate poisoning. You know, now if you know these symptoms, you can easily identify. A patient is coming to you, you are sitting in the OPD, you are the duty doctor, the patient is coming to you and he is having symptoms. So ab batao bachcho, what are the symptoms will be there? There will be increased secretions. Okay, so he will be having increased secretion, first thing. Second thing, there will be increased cognition. The patient will be agitated, he will be agitated, right? Third thing, he will be having meiosis. When you open his pupil and you will be looking at the eyes, you will be finding some kind of meiosis, right? Her or his salivary gland will be contracted. Okay, because of that, what will happen? Due to contraction, what will happen? There will be drooling of saliva. You will be finding some salivary secretions. Bronchus will be constricted. He will be having difficulty in breathing, right? He will be having urination. His clothes will be wet, right? He will be having increased peristalsis. Maybe he has defecated, right? So these are the symptoms. These are the parasympathetic symptoms. If you know this, you will easily identify that patient is having some kind of organophosphate poisoning. Now what you need to do, you need to give certain drugs that would be blocking this, right? And that would be your atropine. Okay, that would be anticholinergic drug that you can utilize along with the pralidoxime or PAM. We can call it PAM, right? So this is how you are going to utilize this particular set of information, right? So what would be the answer here? Answer would be D. Okay, epinephrine is the drug of choice for cardiac arrest, guys. Cardiac arrest means what? The patient is lying down, nothing is working, all the receptors are gone, right? No breathing, there is no circulation. The drug of choice will be epinephrine. Okay, norepinephrine we are using for the shock patient. Along with the dopamine, we are using norad-dopa, and acetylcholine we are using for increasing the cognition, right? Acetylcholine, succinylcholine, right? So these are the things that you should be knowing about this particular thing, right? Now let's move on to the next thing. Next question, question number 4. The image below shows which of the following type of signaling? Try to answer this one, guys. Try to answer this. The image below shows which of the following types of signaling? Try to answer this. So that would be your autocrine. What is autocrine? What is endocrine? What is paracrine? What is exocrine? Let's discuss one by one. So this one is your autocrine. Autocrine मतलब क्या हो गया sir? It is a type of a self-service thing. Okay, it is a type of self-service thing. Very good, Rinkesh. Okay, so it is a type of self-service thing. Let me teach you what is that. So autocoids, you have studied about autocoids. So whatever things are coming from autocrine, these are known as autocoids. What are the examples of autocoids, guys? We are having histamine. Anyone, please tell me the function of histamine. We are having prostaglandins. We are also having leukotrienes, right? We are having multiple things like that. Okay, so these are the particular thing. They are your they are your autocoids. Okay, autocoids. Okay. Second thing, you must have studied about autocoids. Tell me, guys, what is the function of these autocoids? Histamine function. Tell me, guys, prostaglandin, the function will be three important function. There will be pain, fever, and inflammation. Very nice. I'm getting multiple answers, and these are like wonderful discoveries that I'm looking at. So, histamine, guys, simple thing you have to remember. It is having two functions. Autocrine means, you know what happens. Autocrine. Autocrine means this is particular cell. Now, what is happening? It is releasing something, and those somethings they will be working on the particular cell itself. For example, I am having some insect bite over here. Now, what will happen? I will try to itch here, right? Now what will happen? The cells which are adjacent to this particular place, they will be releasing some kind of substances, right? They are known as autocoids. They are coming from autocrine glands. Now what will happen? What are the function that I am asking? What are the function? Suppose histamine is coming out, it will be causing vasodilation and it will be causing bronchoconstriction. Because of vasodilation, what will happen? Vessels get dilate, blood will come out. That would be giving you a red appearance, right? And you will be having some kind of itching, right? It will be causing bronchoconstriction also, right? The function of prostaglandin will be pain, fever, and inflammation, right? So prostaglandin is basically, let me tell you. So for example, this is your cell. Now what will happen? This cell will rupture, right? Every cell is made up of phospholipid layer, right? Whenever there is a rupture of a cell, there is a damage of a cell, what will happen? This phospholipid will be acted upon by an enzyme that is phospholipase A2, and it will be making your arachidonic acid. I am giving you a quick revision, guys. I know you must have studied about this. That is your arachidonic acid. Now this arachidonic acid is acted upon by two things. One is your COX, second one is your LOX. So whenever the COX is working, okay, it will be making your prostaglandins, prostacyclins, all those things it would be making. So basically this will be making prostaglandins. When the LOX will work, that is lipooxygenase, it will be making your leukotrienes. Now what I can do, I can block this COX. These are your drugs, these are your NSAIDs, painkiller. Because we already know the function of prostaglandin will be pain, fever, and inflammation. So whenever you are having pain, you are having fever, you are having inflammation, you are using some kind of non-steroidal anti-inflammatory drugs like Nemucilide, paracetamol, all those drugs, diclofenac, all ibuprofen, all those drugs will be working on this particular thing that would be subsiding your pain, fever, and inflammation. Apart from that, second thing is your LOX. LOX, leukotrienes, the most important question they ask you from physiology. Leukotrienes are the most powerful bronchoconstrictor. Most powerful bronchoconstrictor is not histamine, that is your leukotrienes, right? We are having these leukotrienes, and the LOX inhibitor that we are using is your drug that you are using, that is your montelukast, that is your montelukast. Okay, and the drug which is blocking this particular phospholipase A2, they are your steroids. Okay, they are your steroids. I'm telling you one single line, drug of choice for asthma, that would be your steroids. Okay, that would be your steroid. Okay, yes, yes, very right. LOC inhibitor is xylitol, and leukotriene receptor blocker is your montelukast. Okay, that is very right. Okay, so we are having leukotriene receptor blocker, that is montelukast, and LOX inhibitor, that is your xylitol. Okay, xylitol. So this is the thing you need to remember about this autocoids. Okay, apart from that autocoids, they are self-servicing. Second one is your cell transfer of information via from one cell to another cell via gap junctions. Okay, maximum gap junctions are present in your heart. Okay, maximum gap junctions are present in your heart. You know what happens when a SA node will fire, all the information will be going downwards, and maximum gap junction will be present in your heart, right? Third one is your paracrine system. Paracrine means paracrine, also called as juxtacrine system. Whenever you will heard the term paracrine or juxtacrine, what it means nearby cell. It means nearby cell. Nearby cell. Okay, so here the information is coming and it will be going to nearby cell, so that is your paracrine signaling or juxtacrine signaling. Next one is your endocrine. Endocrine you must have studied. That means the substances, the hormones are coming and it will be going into the bloodstream. All the hormones are going into the bloodstream. That is your endocrine system. Lastly, we are having exocrine. Exocrine will be having ducts. For example, pancreatic duct you are having hepatic duct, bile duct. So all those systems which are having duct, they will be secreting their substances into duct. They are considered as exocrine glands. Okay, they are considered as exocrine glands. Okay, exocrine glands. So what is the answer here? Try to answer this one particular question. Very nice. That is your C. Very nice. Sai Priya, Rinkesh, Manish. Very nice. Okay, so the answer would be C. That is your paracrine signaling. What is happening? It is giving substances to the adjacent cells. Okay, paracrine or juxtacrine signaling. Then moving on to next. Next is your all of the following substances increases the release of gastric acid secretions except. Try to answer this one. All of the following substances increases the release of gastric acid secretions except. Try to answer me. What is happening? Gastric acid is increased. That means what is happening? Increased acid means there is some kind of acidity, right? Now, how you will treat this particular situation? How you will treat this acidity? What you will utilize? And what is the differential diagnosis that you should be having? So, all of you are answering C for this particular question. No. So whenever there is increase in acidity, you know what happens? Increased acid will cause ulcers, right? It will be causing ulcers. Okay, what is the differential diagnosis that you need to have while having this acidity? For example, a patient is coming to you. We are discussing in the case scenario because the questions are coming like that. Okay, the pattern is changing. Even if they are asking you clinical scenarios, you should be understanding how to utilize this information. Okay, theory sabne padha hai, we need to understand how to utilize this particular set of information. So whenever a patient is coming to us with the symptoms of acidity, what is happening? There is increased gastric acid, there is increased HCl. What is happening to the body? There will be some problems, right? And if this acid is increased, it will be causing some kind of a heartburn kind of situation. Or okay, so what will happen? It will be causing symptoms. What would be the symptom? Where you will be finding the pain? In the epigastric region. You will be having pain in the epigastric region. Okay, this is how you are going to approach your patient. The patient will come to you, he will be having pain in the epigastric region. He might say the pain is radiating to the back, right? So you need to have the differential diagnosis. What is that differential diagnosis? You need to always make a differential diagnosis with MI, that is myocardial infarction, right? It can be myocardial infarction, and you miss if you misdiagnose it, what will happen? Your patient might land up in a situation where you are not able to treat him, right? So you have to be very careful. If a patient is coming to you with gastric problem, what you will be doing? First thing you will be doing, you will be giving some kind of antacids. Some kind of antacids. What will happen? The patient is coming to you, he has eaten lots of things. I know you guys must be answering pantoprazole, but no, first step you would be utilizing is your antacids. For example, the patient had last night, he had something, and because of that, what is happening? He is having this kind of situation. First thing, you will be neutralizing that acid that is already present. That would be your antacids. Apart from that, you can use H2 blocker drugs. H2 blocker drugs are your ranitidine. If the patient is full stomach, you can use these drugs. They will be working for 6 hours. Okay, apart from that, you can also use PPI. PPI are the drug of choice for every condition, but the most importantly, PPI you should be giving empty stomach early morning. Empty stomach. They are a kind of hit and run drugs. So that they would be utilizing for 24 to 48 hours. They will be killing a particular cell, that is your parietal cell. What is that cell? Parietal cells. HCl is secreted from parietal cell. Okay, so it will be killing your parietal cell, and these are your PPIs. Okay, so now you know, if a patient is coming to you with full stomach, you will be utilizing antacids. Okay, Gelucil, anything you want to utilize. Second thing, you will be using some H2 blockers. If he is coming again, you will be prescribing some H2 blockers like ranitidine, cimetidine, nizatidine. Okay, and ultimately you can use proton pump inhibitors. But all of these are secondary thing. First of all, you need to make the differential diagnosis with MI. You will be getting a ECG done. Okay, you will be getting an ECG done, and in ECG, if you are finding there is no ST elevation, nothing is there, everything is fine, then only you will be suspecting that the patient is having this particular thing, right? Here the answer would be somatostatin, guys. Somatostatin is a universal inhibitor. It is a universal inhibitor. Wherever you will study about somatostatin, it will be causing inhibition. For example, right now we are studying it in gastric acid, right? We will be studying this particular thing in pancreas also. Alpha, beta and delta cells we are having. Delta will be releasing somatostatin. What it will be doing, it will be blocking glucagon, it will be blocking insulin. Okay, so always remember, somatostatin is always inhibitory function. Okay, inhibitory function. Histamine, we are having H2 receptors, not H1. H1 is for allergic response. We are having H2 receptor here. Histamine, we are having 4 receptors. Okay, gastrin is coming from the G cells. Okay, G cells will be causing increase of gastrin. And acetylcholine, I have already taught you, we are having which receptor from parasympathetic nervous system? That is your M1 receptor. Remember, we have seen M1 receptor, they are increasing the secretion of acid. Now you understand how they are increasing the secretion of acid. And we are utilizing some drugs nowadays, we are not using. These are your pirenzepine and talenzepine. They are basically M1 blockers that we are utilizing in all the times, right? So this is how you are utilizing this situation. Yes, we can use octreotide for somatostatin. We can use for in the place of somatostatin. Okay, that is your octreotide. We can use for like esophageal varices, other things. Okay, so this is basically your parietal cell. Now look here, what are the things that are happening? First thing, acetylcholine will be activating this via which receptor? M1 receptor. Second thing, histamine will be activating this via which receptor? H2 receptor. And third thing, gastrin will be activating this. Okay, so gastrin is coming from which cells? G cells. Okay, gastrin is coming from G cells. And if there is tumor of gastrin, if there is tumor of G cells, what is that disease called as? Please try to mention in the chat box, guys. Tumor of G cells or G cell gastrinoma, what do we call it? Okay, now what is happening, we are having H2O plus CO2. This is your carbonic anhydrase pump. Ultimately, chloride will be coming from here and proton will be coming from here. So H plus and chloride will be binding together and it will be making what? Your HCl. It will be making your HCl, that is your hydrochloric acid. Okay, hydrochloric acid, guys. Now, can anyone tell me which type of pump is this? Try to answer. Okay, facilitated diffusion, primary active transport, secondary active transport, or osmosis. What type of transport is this? HCl. This is a proton pump. Yes, Rinkesh, it is a gastrinoma that is known as, very good, Rinkesh. That is known as Zollinger-Ellison syndrome. That is known as Zollinger-Ellison syndrome. That is basically a tumor of G cell. G cell gastrinoma is known as Zollinger-Ellison syndrome. Very good, very good. Okay. So look here, guys. Next thing. Now you understood how you will treat this particular situation, and now you understood what are the things that are activating it. Okay, this is a I9 set repeat question, has been asked in NEET PG as well, right? So what are the things that are activating the parietal cell? First one is your acetylcholine. Second one is your histamine via H2 receptor. Third one is your gastrin. Only three things. Okay, and what is the drug that you are utilizing? Proton pump inhibitor that would be killing this proton pump. This proton pump will be killed, and this proton pump, if get killed, it needs to regenerate and it will take some time. That would be 24 to 48 hours, right? So that is why we are using PPI early morning, and that would be working for a next day, right? 24 hours. Okay, I think you guys are done with this. Okay, try to tell me some important information. Let's discuss about some ulcers also. Okay, so we are having gastritis also. What is that gastritis, guys? How many types of gastritis do we have? We are having type A, type B and type C gastritis. Okay, A is due to autoimmune. They have asked you the question, what is the antibody here, what is the antibody that is causing type A gastritis? That is your, try to answer guys, anti-parietal cell antibody. This is your anti-parietal cell antibody. Okay. Type B is due to what? Type B is due to bacterial infection. What is that bacteria? We will be studying tomorrow, right? That bacteria will be Helicobacter pylori. Okay. Tomorrow, please try to answer what is the strain that we are using for Helicobacter pylori. Okay. Type C will be cytotoxic. That can be due to any kind of drug, be it NSAIDs, be it some chemical the patient is ingesting, some kind of chemicals, right? So these are the three types of things we are having: type A, type B, and type C gastritis. Okay. Apart from that, when we talk about some peptic ulcer disease, we are having peptic ulcer in the two places. It can be at the two places. Either it can be gastric ulcer, either it can be duodenal ulcer. Okay. The ulcer can be present in the gastrium region. The ulcer can also be present in the duodenal region, right? So if the ulcer is present in the gastric region, what will happen when the patient is eating something? When the patient is eating something, what will happen? If the patient is eating something, he will be having pain because the acid will release. Okay, this is your GIT. Now what is happening here is some kind of ulcer. Now what will happen when the patient will eat something? What will happen? The acid will come, and that acid will cause the pain, right? So these are the patient who will be having pain, who will be having pain after eating, and this pain can be relieved by vomiting. This pain can be relieved by vomiting. When the patient is vomiting out, what is happening? The acid will be going out, and that is how this pain can be subsided. And these patient will be thin patient. You will be understanding these patient will be thin patient. Yes. Okay. And second thing will be duodenal ulcer. If the ulcer is present in the duodenum, you must have seen, you are having some friends, those people who are sitting in the library or sitting in the classes or every time eating something, and they will be always telling that whenever I am hungry, I will be having aggravation of the pain, right? So that is known as hunger pain. There are some people who are always constantly eating something after a 2 to 3 hours of break, they are eating something. Okay, so these patients who are having duodenal ulcer, they will be having hunger pain, right? What will happen when they eat something? Pain will be relieved. Pain relieved by eating. Okay, the pain relieved by further eating, right? And what is the treatment for both of them? You will be treating both of them with triple therapy or quadruple therapy. Triple therapy is your cap, that is clarithromycin, amoxicillin, along with some kind of a PPI. In quadruple therapy, what we are giving, we are adding bismuth. Okay, bismuth subsalicylate, or we can also use sucralfate. Okay, just a quick recap, guys. We can also use, yes, that is the artery that can damage in the complication. Okay, in the complication it can damage, right? We are using sucralfate. Okay, we can use sucralfate. What sucralfate will do, it will make a covering around the ulcer. Okay, it will make a covering around the ulcer, and that would be preventing the pain from the ulcer. Okay, so these are triple therapy and quadruple therapy. Triple therapy, I don't want to go into more details. We will be discussing them in medicine, right? Next thing is your, try to answer this question. If you are having any doubts regarding that, you can ask me now. Okay, try to answer this question. Which of the following will be involved in clotting cascade system, guys? Clotting cascade system, which of the following will be involved? Okay, so what is the feedback, guys? What is the meaning of feedback? Feedback means what is happening if there is increase in BP and it will be leading to decrease in BP. Okay, that is a type of negative feedback. Positive feedback means what? Increase in something will lead to more further increase in something, right? That is a type of positive feedback. And feed forward or anticipatory system are basically one of the same thing. Now what is happening, just for example, let me give you example of all of them. Okay, feed forward, what will happen? For example, I am sitting here, you guys are sitting here for long time. Now what is happening? You guys must be hungry, so just thinking about the food. For example, you guys are hungry, and just thinking about the food, what is happening? You will be having secretion of acid in your GIT. Secretion of acid in GIT, and not very few acid, that would be approximately 30% of acid secretion in GIT, just thinking about the food. That is known as psychic stimuli. Psychic stimuli, that would be an example of feed forward or anticipatory system. That means your body is anticipating something. For example, let's say I just want to go to the gym. Okay, so just thinking about gym, just thinking or getting ready about gym, what will happen, my heart rate will automatically increase, my body will automatically increase my heart rate, it will automatically increase my respiratory rate. Okay, so these are the two examples that you should be remembering. So the first example is just thinking about the food, your GIT will be having acid secretion. Okay, that is a psychic stimuli. And just thinking about the exercise, just thinking about the exercise, my body will be increasing my heart rate, my respiratory rate. That is the example of anticipatory system. Okay, here they are asking about the clotting cascade system. Okay, this is the question they have asked you. So for positive feedback we are having a mnemonic, that is your claps. Okay, we are having a mnemonic for positive feedback. Positive feedback is seen in particular situation. First one is your clotting system. Okay, clotting system, that means you must have seen the clotting cascade. There is 13, 12, 11, 10. Okay, they will be just activating other systems. So that is a type of positive feedback system. Second one is your LH surge. Second one is your LH surge. LH surge, if there is estrogen, what will happen, there will be increase in the level of LH. That is your LH surge. Next one is your action potential. Action potential, once the sodium will come inside, what will happen, it will be transmitting the information forward, right? P for parturition, once the baby is coming out, that is also known as Fredruson reflex. Once the baby is coming to the cervix, what will happen, it will be, the baby will be coming out, definitely he will be coming out, it will be inevitable to stop that, right? So that is also a type of positive feedback. Okay, and lastly we are having shock. Lastly we are having shock. So what is the mnemonic that you have to remember? The mnemonic is claps. Okay, so we are having three types of cascade, three types of feedback system. Feedback system, why they are important? To maintain the homeostasis of the body. For example, what is happening outside, there is too much of heat, what my body will do, my body will try to cool down, right? So basically it is the maintenance of internal environment as compared to external environment, that is known as homeostasis. Okay, so usko balance karne ke liye we are having certain mechanisms. These are the feedback mechanisms. क्या हुआ, बहुत ज़्यादा TSH आ गया, बहुत ज़्यादा TSH आ गया तो क्या होगा, बॉडी ऊपर मैसेज जाएगा TSH को कम कर दो. सो दैट इज अ टाइप ऑफ नेगेटिव फीडबैक. पॉजिटिव फीडबैक, द एग्जांपल वुड बी क्लैप्स. ओके, C for clotting system, L for LH surge, A for action potential, P for parturition, and lastly we are having shock. Okay, feed forward and anticipatory, they have asked you question in the previous year exams. Hot topic है, so please try to understand this. Okay, two examples I have given you. Okay, so the answer will be clotting cascade will be a type of, clotting cascade will be a type of, very good Rinkesh, Sahana. Okay, so that would be a type of positive feedback system. Okay, moving on to next question, which of the following touch receptor is best suited for reading in blind people? Those people who are blind, you know, they can study, right? They can also study. So please try to answer this question. Question number 7, how they will be looking at the things. Till then, let me tell you one more important question that is coming from this particular part. That is, Meissner's corpuscles will always be present in, they will be present in, Meissner's corpuscles will be present in which layer? Present in, Meissner's corpuscle will be present in dermis, guys. Just a moment, guys. Meissner's corpuscle will be present in dermis, whereas Merkel cell will be present in epidermis. Okay, epidermis, we are having that 5 layers. Okay, I've taught you in dermatology also, that dermatology video. Okay, so Merkel cell will be present in epidermis, Meissner's corpuscle will be present in dermis. Okay, then we are having Pacinian corpuscle. Pacinian corpuscle is for the high frequency vibrations. Ruffini is ending for the skin stretch and some kind of vibrations. Okay, yes, Cypria. So what would be the answer? Blind people, how do they study? How do they study? Blind people, what they are utilizing? This is a very important question. Meissner's corpuscle, Merkel cell, Pacinian corpuscle, Ruffini is ending. Try to answer, guys. B Cypria. Yes, that would be your Merkel cell. Look here, guys, we are having certain cells that we need to remember. Okay, in the skin, we are having some kind of touch receptor. For example, we are having some touch receptor, right? For vibration, for pressure, we are having different things. So we are having this one, Meissner's corpuscle. This one is more present in lips and fingertips. They are for the low frequency vibrations. Okay, they are just identifying the gentle tap like that. Okay, so they are just identifying the gentle tap and they are more present in lips and fingertips. This was the question they have asked you. Second thing, Merkel cell. Merkel cell is present for uh, touch. They are basically type 1 slow adapting touch receptor. So they are present for touch and sustained pressure, and they are very sensitive to edges and corners, and this type of reading is known as braille reading. You know what happens, those people who are having braille books, what they how they are studying, they are having some edges or corners. For example, they are having this type of uh, structures. Okay, they are having these things, and the people will be studying like that. They are just touching them and identifying how it is happening. Okay, so this is known as braille reading. This is known as braille reading, and the receptor which are responsible for braille reading will be Merkel cell. Okay, next one is your Pacinian. Pacinian is for high frequency vibrations, and lastly we are having Rufinus ending. Generally they are present in joint capsule for they are for the skin stretch or pressure sensations. Okay, so these are the different type of cells we are having. The answer would be Merkel cell. Okay, the answer would be Merkel cell. Please try to answer this question. A patient presented to OPD is diagnosed with anemia, guys. Okay, in his lab report, and report is saying that MCV is less than 80 and hemoglobin is 8. Okay, the doctor prescribed him the iron tablets, which are the things he should be avoided with iron. So the simple question here, they want to know what are the things that you should be avoiding with the iron. Okay, the simple question is that. Sometimes, you know, there is a long big history, but you should be starting the question from the last line. You should be understanding what the question wants to know. Here they have given you some histories, but they really want to know what should be avoided, and this is a previous year question. Very good, Rinkesh Zarka. So that would be your tea. The patient should not take tea from along with this particular thing, right? So can anyone tell me, let's discuss a little about anemia as well. Okay, can anyone tell me what is the normal level of RBC? RBC will be 4.5 to 5.5 million cubic mm of blood. Okay, out of that hemoglobin they have given us 8 hemoglobin. Can anyone tell me when do we need to transfuse the blood? How much is the hemoglobin when we need to transfuse the blood? And 1 unit of blood will be including how much amount of RBCs? Okay, 1 unit of blood, we write unit like that. How much amount of RBCs will be there? 1 unit. So try to answer. Very nice, Vijay, Rinkesh. So we will be transfusing the blood whenever there is hemoglobin less than 7. For example, the hemoglobin is given 4. Now what I need to do, I need to make it 7 first. Okay, so how I can make it 7? I need to add 3 units of blood. 3 units of blood means what? How many, how much amount of blood I need to add to this particular patient? Try to answer, guys. Okay, so I will be adding 3 units of blood, and now what is happening, this 1 unit of blood will be increasing hemoglobin by 1%, 1 gram percent, or just by 1, you can remember. So if I am adding 1 unit of RBC, look here, a patient is coming to you with a hemoglobin of 4. Now what I need to do, I need to add some RBCs. I will be giving 1 unit. What will happen? The hemoglobin will become 5. I will be giving another 1 unit. What will happen? Hemoglobin will become 6. Then I will be giving again, and that would be becoming 7. Now what will happen? After 7, I will stop the blood transfusion. No, it's not 250 ml. That would be 350 ml in India. 450 you will be finding in US, right? So 350 ml will be in India, right? So we will be taking the blood to 7. Then what we will do, we will do a test, that is MCV. mean corpuscular volume, that is telling us about the size of the RBC. Okay, RBC can be small if it is less than 80, the RBC can be small. If it is more than 100, the RBC can be large. Okay, so what are the things that we are having here? That is your very famous mnemonic, that is your Sheetal, right? It can be sideroblastic anemia, it can be iron deficiency anemia, it can be thalassemia, it can be anemia of chronic illnesses, it can be lead poisoning. Okay, so these are all the causes that can happen. Okay, these are all the causes of less MCV. Okay, here also in the case itself, the patient is prescribed with the tablets of iron, right? Second thing, if it is more than 100, what can be the cause? What can be the cause if it is more than 100? Till then, please tell me, lead poisoning patient will be having a specific type of pigmentation. What is that? Okay, if it is more than 100, it can be B9 deficiency, it can be B12 deficiency. Okay, folic acid and cyanocobalamin, that is methylcobalamin, that is vitamin B12. Okay, so we will be looking at MCV and identifying these things. If MCV is low, sideroblastic, you will be easily identifying that in the peripheral smear. Iron deficiency is the most common one. Thalassemia, you will be checking for Menser index, and thalassemia patient already they must be diagnosed, right? Anemia of chronic illnesses, when you are taking the history of the patient, you will be ruling out this particular thing. And lead poisoning will be having aplastic anemia, yes, we can say, and lead poisoning will be having Rendro pigmentation, right? B9 or B12 deficiency, you can again check between them with the help of a test, that is methylmalonyl coenzyme A test, that you must have studied in your biochemistry, right? Just for the quick recap, we are going through these things. Okay, so after that, what will happen? You are taking it to the 7. Now, for example, our patient is having iron deficiency anemia. Let me give you a little bit more brief insight. Okay, so I need to give this patient oral or IM drug. Remember about iron, if you are giving orally or you are giving IM or IV, there will be same bioavailability, so there is not gonna be any kind of difference in absorption, right? First thing, when you are giving iron, it will be, when you are giving iron for 21 days, it will be increasing by 1 gram percent, right? When you are giving iron for 21 days, that would be increasing by 1 gram percent. So it is 7. Now after 21 days, it will become 8. Okay, for next 21 days, it will become 9. So this is how we are checking that. Okay, so we should be avoiding these patients for the T. Okay, T, we should be avoiding T. Apart from T, there are other things like phytates, oxalates, coffee, all those things we need to avoid. Okay, what are the things that are increasing the absorption of iron? That is your vitamin C and acids. Okay, iron metabolism is a very important thing. Let's see how the iron is getting metabolized in the body, how we are absorbing the iron. Okay, so first of all, tell me, what is ferrous? What is the form that we are eating? We are eating ferrous or ferric? What is the basic difference? Okay, so difference comes in the word itself, C. In the ferric, that is C, that means it is Fe3 plus. Okay, just remember, don't get confused. Fe3 plus, that is ferric. Fe2 plus will be ferrous form. Okay, now what is happening? There are two types of iron in the body. One is heme iron. Hemoglobin will be having iron. So whenever there will be damage of hemoglobin, what will happen? The iron will come out, right? Now we are having this food iron. Whatever iron we are eating in the food, that is your which form? Ferric form. That is your ferric form, that is Fe3 plus. Now try to understand, this Fe3 plus will be going to this duodenum for absorption, but it cannot get absorbed directly. It will be converted into Fe2 plus. Okay, Fe3 plus we are eating in the ferric form, that will be converting into ferrous form. Okay, now what is happening? We are having a receptor that is known as divalent metal transport. इसके नाम में ही लिखा है divalent. So that means it will be transporting something that will be having two valencies. And this was the question they have asked you. Okay, NEET PG question है, DMT1 is the receptor for entry of Fe2 plus. Now what is happening? This Fe3 plus that you are eating from your food, जो भी खाने में आपने खाया, that would be going to divalent, that would be going to duodenal साइटोक्रोम बी, एंड दिस डिओडोनल साइटोक्रोम बी, इसका फंक्शन क्या है? इसको Fe2 प्लस में कन्वर्ट कर देगा. नाउ दिस Fe2 प्लस विल बी गेटिंग इनसाइड, इट विल बी गेटिंग इनसाइड विद द हेल्प ऑफ डाइवेलेंट मेटल ट्रांसपोर्ट. ये अंदर आ गया. नाउ इट कैन स्टोर्ड इन द फॉर्म ऑफ म्यूकोजल फेरिटिन. ओके, Fe2 प्लस की फॉर्म में इट कैन गेट स्टोर्ड हियर. Okay, either it can be utilized for oxygenase. Okay, now what will happen, ultimately whenever we require iron, it will be going out. Storage form हो गया. Now it will be going out. It will be going out via a pump that is known as ferroportin 1. Ferroportin 1. Okay, अभी क्या आएगा बाहर, because already inside was Fe2 plus, so now again it is also coming Fe2 plus outside, right? Now this Fe2 plus will be converting into Fe3 plus, because transport form जो होगा, फूड जो खाया था that is also Fe3 plus, now also it will be Fe3 plus, right? So जो खाया है वो बाहर आ गया, एंड इट विल बी कन्वर्टिंग विद द हेल्प ऑफ दिस पर्टिकुलर थिंग दैट इज हेपेस्टिन. हेपेस्टिन, ओके. हेपेस्टिन का फंक्शन क्या होता है, Fe2 प्लस को Fe3 प्लस में कन्वर्ट करना. एंड नाउ दिस Fe3 प्लस विल बी बाइंडेड विद द transferrin. Transferrin is the taxi, right? It will be transferring the Fe3 plus. Iron transporter, transferrin. Copper transporter, try to answer in the chat box. What is the transporter for copper? ओके, सो अभी क्या होगा, ये ट्रांसफेरिन इसको उठा लेगा, एंड नाउ इट विल बी सप्लाइंग टू डिफरेंट पार्ट ऑफ द बॉडी. फॉर एग्जांपल लिवर, फॉर एग्जांपल बोन मेरो विल बी हैविंग एरिथ्रोपोइसिस, इट विल बी रिक्वायरिंग सम आयरन, राइट? सो फ्रॉम वेयर दिस आयरन इज कमिंग, दिस आयरन इज कमिंग फ्रॉम द स्टोर्स itself and it will be utilized for blood production. Okay, now the most important thing from this particular thing that we have seen is this hepcidin. Hepcidin will act as a brake, guys. It is a brake. Okay, now this hepcidin will be a brake on ferroportin. ये क्या करेगा, ferroportin को रोक देगा. अगर ferroportin रुक गया, what will happen, this Fe2 plus can come out? No, Fe2 plus बाहर नहीं आएगा. So hepcidin will be acting as a brake, right? Now there is a mutation of HFE gene, or there is a mutation that would be leading to a disorder that is known as chromatosis. That is known as hemochromatosis. मेडिसिन में हम लोग पढ़ेंगे, that is hemochromatosis. So basically प्रॉब्लम कहाँ है, ये हेप्सिडीन काम नहीं कर रहा, दिस ब्रेक इज नॉट वर्किंग, एंड इफ दिस ब्रेक इज नॉट वर्किंग व्हाट विल हैपन, बहुत सारा आयरन बाहर आ जाएगा Fe2 प्लस, बिकॉज दिस इज अ ब्रेक. अगर ब्रेक फेल हो गया क्या होगा, व्हाट विल हैपन, दिस फेरोपोर्टिन विल वर्क मोर, राइट? अगर फेरोपोर्टिन ज़्यादा काम करेगा तो क्या होगा, Fe2 प्लस ज़्यादा बाहर आएगा. Fe2 प्लस ज़्यादा बाहर आएगा, इट विल बी गेटिंग डिपॉजिटेड इन द certain organs, it will be depositing in the liver, it will be depositing in the bone marrow, it will be causing damage to the body, right? Hemochromatosis करा देगा, right? You understood? Bronze diabetes. Okay, so what will happen, basically first thing you have to remember the ferrous and ferric. This concept is clear. Ferrous means Fe2 plus, ferric means Fe3 plus. Whatever food we are eating, it is in the Fe3 plus. Let me recap everything. Whatever food we are eating, it will be in the Fe3 plus. Now this Fe3 plus will be going into the duodenum. Absorption कहाँ से होगा, duodenum से होगा. So it will be going into duodenum. This Fe3 plus will be converting into Fe2 plus with the duodenal cytochrome B enzyme. Now this Fe2 plus can get inside my blood vessels, right? Now it can get inside because with the help of a transporter that is known as divalent metal transporter 1, DMT1. अब ये अंदर आ गया, it will be getting stored in my body in the form of a ferritin. Ferritin में Fe2 plus की form में store होगा. Whenever required, it will be coming out from ferroportin, and this ferroportin is tightly regulated with the help of hepcidin, which is acting as a brake. So जब भी चाहिए होगा क्या होगा, हेप्सिडिन का लेवल कम हो जाएगा, हेप्सिडिन कम होगा, फेरोपोर्टिन एक्टिवेट हो जाएगा. व्हाट विल हैपन, Fe2 प्लस विल कम आउट, इट विल बी कन्वर्टिंग विद द हेल्प ऑफ हेपेस्टिन into Fe3 plus, and this hepastine will be taken up by the copper by the transporter of the iron, that is transferrin. The transporter for copper, very good Cyprior Rinkish, that is ceruloplasmin, that is your ceruloplasmin. Now this transferrin will be taking up this iron and it will be utilized for the blood production and multiple things that are requiring for your body, right? Did you understand this particular question? Did you understand the iron metabolism? Moving on to next is your, in the given graph below, phase 3 is due to what? Are you guys understanding? Do let me know in the chat box, guys. In the given graph below, phase 3 is due to what? phase 3 किसकी वजह से होगा? Okay, so What is this graph? This is known as action potential graph. This is an action potential graph, guys. Okay, so just try to understand the basic concept, what is happening here. For example, I'm touching myself here. What is happening? The impulse is going in my brain and it is coming back. How it is going, how the things are working in the body itself, right? We are learning that thing, right? So we are having phase 3. First of all, just try to understand this is a normal cell. Everyone is telling B. Yes, that answer would be B. So this is a normal cell. What is happening? Potassium is always leaking out from that cell. Every cell potassium is leaking out, and potassium is leaking out, and because of that leaking out of that potassium, what is happening? It is the maintenance of RMP. RMP जो मेंटेनेंस होता है वो किसकी वजह से होता है? पोटेशियम इफ्लक्स की वजह से होता है. फर्स्ट क्वेश्चन डन. सेकेंड थिंग, नाउ व्हाट इज हैपनिंग? अभी कोई इन्फॉर्मेशन पहुंचाना है सेल के अंदर. फॉर एग्जांपल दिस इज पॉइंट ए, दिस इज पॉइंट बी, एंड हियर वी आर हैविंग मल्टीपल सेल्स, राइट? Here we are having multiple cells. Now what will happen? Neurotransmitter we have already studied, acetylcholine aega. Ultimately that would be giving rise to sodium. One thing you have to remember, sodium is always more outside. Sodium is always more outside and potassium is always more inside. This is also a question, right? And potassium is always leaking from the cell, causing the resting membrane potential, right? Now what is happening? This channel will open, some channel will open, and because of that what is happening? This sodium will come inside. When the sodium will come inside, sodium is a positive charge. What will happen? This is 0, sorry, this is minus 90, this is minus 90, this is 0, this is 10, right? So what will happen when the positive charge is coming inside? What will happen? It will go towards the positivity. Okay, तो सोडियम अंदर आने की वजह से क्या हुआ? That is known as depolarization. Okay, इसको क्या बोलेंगे? Depolarization बोलेंगे. And because of depolarization, simple meaning of depolarization, systole, contraction, basically they are same thing. They are synonyms. We can tell them synonyms. Okay, depolarization, systole, contraction. So what will happen? जैसे ही सोडियम अंदर आएगा, this one will be raised. कहाँ तक जाएगा? It will be going till +10. Okay, +10 तक जब ये चला जाएगा तो what will happen? There will be some potassium channels which will open. जैसे ये +10 को टच करेगा this point, what will happen? The potassium channel will open, and because of potassium what going out, what will happen? Charge कम हो जाएगा. What will happen? Sodium is coming in and potassium is going out. What will happen? There will be some decrease in the पॉजिटिविटी. ओके, सो ये हो गया. इसके बाद में व्हाट विल हैपन? द कैल्शियम चैनल विल ओपन अप. कैल्शियम चैनल विल ओपन अप phase 2, and the calcium is coming inside, potassium is going outside. That would be giving me a plateau. Okay, कैल्शियम अंदर आ रहा है, पोटेशियम बाहर जा रहा है. That would be giving me a plateau, and after sometimes what happens? This calcium channel will be stopped. If this calcium channel will be stopped and potassium is continuously leaking out, what will happen? It will be leading to the again regain of normal potential, that is maintenance of electron negativity. ये फिर से नेगेटिव की तरफ आ जाएगा. That is the phase 3. Phase 3 is due to potassium efflux. Now you must have understood what is happening. So this is your sodium coming inside, potassium going outside, calcium is coming inside, potassium is going outside, and now what will happen? This sodium will be going to the cell B. Now this cell will get depolarized. First this cell will get depolarized because positive charge is coming. Now this cell will get depolarized. Again this cell will get depolarized. Likewise this cell will get depolarized, and the cell which is in the back side, what is happening? It will be repolarizing again. This is depolarization step. This is repolarization step. Are you guys understanding what I want to convey? This is how the information is going in the पॉजिटिव डायरेक्शन. दिस इज व्हाट वी आर स्टडिंग अबाउट द एक्शन पोटेंशियल. इसका मतलब समझ में आया क्या होता है? I know you have already remembered phase 0 is depolarization, 1 is what, but this is what is happening when a cell is getting depolarized. The cell is contracting and it will be transferring the information to another cell, to another cell, to another cell. This is how the impulse is traveling in our body. Okay, now with the I will teach you in the further question, okay, about the myelin and all. Okay, so phase 3. Now let's see what are these phases. If you just want to remember what are these phases, you can directly remember as well. Phase 0 is due to sodium influx, that is the positive charge coming in. Phase 1 is due to potassium efflux. Okay, potassium is going out. Phase 2 is due to calcium influx, that means a lot of calcium is coming in. Okay, and phase 3 is due to again potassium efflux. Potassium efflux मतलब बाहर जा रहा है, influx मतलब अंदर आ रहा है. So what is happening in phase 3? Potassium is again going out, leading to what? Resting membrane potential. Okay, that is your minus 90 millivolt. Are you guys understanding? So what would be the phase 3 indicating? That would be your potassium efflux. Very nice, guys. Okay, so now moving on to next question. This is the action potential for cardiac muscle that we have studied. Now let's see about the SA node. This is the action potential for SA node. Okay, just simply remember three things I want to remember. The question that they have asked you, I'm giving you direct explanation. Phase 4 is known as pre-potential. Why? Because SA node is a pacemaker. SA node is a pacemaker. You know, guys, why we call it a pacemaker? Because it will be having a restless membrane potential. It will be having a restless membrane potential. It is not RMP, it is restless membrane potential. That means it will be oscillating between -60 to -40 millivolts. इनका पोटेंशियल चेंज होता रहता है. ओके, तो फेज 4 किसकी वजह से होगा? फेज 4 इज ऑल्सो नोन एज प्री पोटेंशियल. इट इज ड्यू टू थ्री थिंग्स. ओके, फर्स्ट थिंग, इट इज ड्यू टू डिक्रीज पोटेशियम इफ्लक्स. सेकेंड थिंग, यहाँ पर होते हैं फनी करंट. ओके, सेकेंड थिंग इज ड्यू टू फनी करंट. And third thing, we are having transient type of calcium channel, T type calcium channel. And this is the question they have asked you. Phase 4 is due to, even if you don't want to understand, just remember this. Phase 4 is due to three things: decreased potassium efflux, funny current, and T type calcium channel. This is your phase 4. Okay, this is your phase 4. This is your phase 0. Phase 0 again will be, phase 0 will be same. Phase 0 will be depolarization, and here depolarization is due to again calcium channel, but this time long lasting type of calcium channel, that is L type calcium channel. L type calcium channel is responsible for the depolarization. And repolarization, always guys, repolarization is due to potassium efflux. Repolarization is due to potassium efflux. So I want you to remember only 3 points about this. First thing, normal cell, if I'm talking about, this is your cardiac muscle cell, and this is your SA node. How you will differentiate and what are the points that you should be knowing? First thing, they will ask you, phase 0 here is sodium influx, that is depolarization. Phase 0 here also calcium influx, that is depolarization. First difference you have understood. Second difference is phase 4. Phase 4 here will be, here the phase 4 will be resting membrane potential, but here the phase 4 will be pre-potential. Here the phase 4 will be pre-potential. So they can ask you direct question based on this. And phase 3 will be same in both the cases, that is due to potassium out. So that is the single point that you need to remember. If I am the examiner, I would be asking this type of question. Okay, so that would be pre-potential. Pre-potential is due to three things, and they can give you all except question based on this. Okay, so are you guys understanding this? If you don't understand, do let me know. Okay, next is question number 10. Please try to answer this. In the following graph, the point C correspond to which heart sound and why? Try to answer this one. In the following graph, the point C represent to which heart sound? This is a repeat question. They have asked multiple times, guys. Try to answer. Look here, let me teach you. And this is very simple thing, guys. If you understand this one will be very simple. Okay, so this is your point A. Point A will be, let me teach you about the walls first, so that would be easy for you. Okay, this is your heart. Your heart will be having 4 chambers. From the basics, guys, nothing fancy. If you have not done, don't worry. Okay, so this is your right atrium, because right is coming first. Atria is above. This is your right ventricle. This is your left atrium. This is your left ventricle, right? From here the aorta will be coming, aorta. Okay, and that would be supplying blood to the complete body. And from here in the right atrium, what is happening? The vena cavas will be draining the blood. Superior inferior vena cava will be draining the blood into right atrium, right? Between right atrium and right ventricle there will be which valve? Tricuspid valve. तीन cusp होंगे, तीन पहले आता है, that would be tricuspid valve. Between left atrium and left ventricle there will be bicuspid valve. This is you have understood, right? Now we will be starting from the basics. Okay, अभी क्या होगा? Left ventricle will be having a thick wall. Simple things. Okay, left ventricle will be having a thick wall. Now try to understand. You have understood about the mitral wall. This bicuspid wall is also known as mitral wall. This bicuspid का दूसरा नाम क्या है? Mitral valve. Okay, aorta के पास में जो valve है उसको बोलते हैं aortic valve. This one is your aortic valve. Okay, so two things we have to remember. First thing, whenever a door is closing, जब भी कोई दरवाज़ा बंद होगा तभी हार्ट साउंड आएगा. हार्ट साउंड कब आएगा? जब दरवाज़ा बंद होगा. whenever there is closure of any wall, right? Now what is happening? Try to understand. This is known as pressure volume loop, and this is very simple. If you understand this, your life will be easy. Okay, so try to understand from the point A. Okay, point A पे क्या हो रहा है? Try to understand this. Point A, mitral valve is getting closed. Okay, look here, mitral valve is getting closed. Mitral valve closure. Okay, and that would be giving you which sound? That would be giving you S1 sound. Okay, whenever there will be closure of mitral valve कौन सा है? ये वाला. अगर ये बंद होगा, ये दोनों साथ में चलेंगे. whenever there is closure of this valve, what will happen? You will be having S1 sound. अभी S1 sound हो गया. Now what is happening? Look here, जब ये valve बंद होगा, when this valve is getting closed, what is happening? सारा blood नीचे आ गया होगा. Just assume this for a minute. Okay, what is happening? सारा blood नीचे आ गया. सारा blood नीचे आ गया. जब ये दरवाज़ा बंद हुआ तो आवाज़ आई. ओके, अभी क्या है? लेफ्ट वेंट्रिकल और राइट वेंट्रिकल के अंदर बहुत सारा ब्लड है, राइट? सो इट नीड्स टू जनरेट द प्रेशर, क्योंकि ब्लड पूरी बॉडी में भेजना है. सो वी नीड टू जनरेट द प्रेशर, एंड दिस इज नॉन एज आइसोवोल्यूमिक कॉन्ट्रैक्शन. दैट मीन्स हाउ मच इज द ब्लड देयर? 120 ml ब्लड है. Now what your heart needs to do? It needs to generate pressure. Okay, it needs to generate pressure, and how they are generating the pressure? By isovolumic. That means iso means same, volumic means volume, and contraction, that means it will be contracting and generating the pressure. Okay, at point B what will happen? Try to understand this. Abhi point B पे क्या होगा? Pressure is approximately around 100-120. 100-120 तक pressure चला गया. Now what will happen? Your valves will open. These valves will open. ये वॉल्व खुल जाएगा, ये भी खुल जाएगा. खुलने पे कोई आवाज़ आएगी? नहीं. दिस वॉल्व्स विल ओपन एंड द ब्लड विल बी सप्लाइड टू कंप्लीट बॉडी. ये दरवाजे खुलेंगे और पूरा खून कहाँ चला जाएगा? पूरी बॉडी के अंदर चला जाएगा. एट पॉइंट बी व्हाट विल हैपन? देयर विल बी ओपनिंग ऑफ aortic valve. There will be opening of aortic valve और ये वाला pulmonary valve साथ में खुलेंगे, right? अभी क्या होगा? There will be two stages you will be seeing. There will be ejection, there will be fast ejection, there will be slow ejection, there will be rapid ejection phase, there will be slow ejection. कुछ भी नहीं है, simple things है. अभी क्या होगा? पूरी बॉडी में ब्लड चला गया. Now ये दरवाजे बंद होंगे फिर से. Now these gates will close again. Now you will be having another sound at point C, and that is due to what, sir? That is due to closure of, I told you, जब भी दरवाज़ा बंद होगा तभी साउंड आएगा. That is due to closure of aortic valve, क्योंकि ब्लड पूरा बॉडी में भेज दिया. They have already given the blood to the body. Now because of closure of this particular valve, you will be hearing a sound that is your S2 sound. Okay, अभी क्या होगा? अब प्रेशर बहुत ज़्यादा है. नाउ वेंट्रिकल्स आर हैविंग अ लॉट ऑफ प्रेशर बिकॉज इसने पूरी बॉडी में ब्लड भेजा है, राइट? सो अगर अभी ये दरवाजे खुल गए, अभी ये मिट्रल और ट्राइकस्पिड वॉल्व खुल गया, तो व्हाट विल हैपन? वॉट एवर ब्लड इज लेफ्ट इट विल बी गोइंग बैकवर्ड, राइट? सो इट नीड्स टू डिक्रीज द प्रेशर. ये प्रेशर कुकर की तरह है, तो पहले क्या करना पड़ेगा? वी नीड टू डिक्रीज द प्रेशर, एंड दैट इज नोन एज आइसोवोल्यूमिक रिलैक्सेशन. दैट मीन्स यहाँ 120 ml था, इन्होंने 70 ml बाहर फेंक दिया, 50 ml यहाँ पर बच जाता है, ओके। एंड दिस 50 ml विल बी डिक्रीजिंग द प्रेशर, ओके। ये प्रेशर कम होगा, प्रेशर कम होगा, और पॉइंट डी पे ये प्रेशर जब जीरो हो जाएगा, देन व्हाट विल हैपन एट पॉइंट डी, व्हाट विल हैपन, अब क्या होगा, वापस से ऊपर वाले, वापस से ये वाले वॉल्व्स खुल जाएंगे, दे कैन ओपन अगेन, दे कैन ओपन अगेन, सो दैट वुड बी कॉजिंग ओपनिंग ऑफ माइट्रल वॉल्व, ओपनिंग ऑफ माइट्रल वॉल्व, है ना। तो ये वापस से ऊपर वाले वॉल्व्स खुल जाएंगे, एंड एट दिस पॉइंट ऑफ टाइम द ब्लड विल बी 50 ml। नाउ व्हाट विल हैपन, देयर विल बी फिलिंग फेज, अभी ये खुल गया, नाउ व्हाट विल हैपन, देयर विल बी फिलिंग फेज, द ब्लड विल बी कमिंग टू राइट एट्रियम एंड लेफ्ट वेंट्रिकल्स, ओके। नाउ दिस वन विल बी फिलिंग, ये नीचे पूरा ब्लड भरेगा, एंड अल्टीमेटली व्हाट विल हैपन, अगेन वापस से मिट्रल वॉल्व बंद हो जाएंगे, blood will be in the ventricles. Now try to understand this complete story, okay, try to understand this. I am dividing this particular thing into two parts. इसमें दो phases होती है, one is diastole, one is systole, okay. Now this is complete process of your heart that is happening, okay. I am revising everything once again. If you are having any doubts, do let me know, okay. So basically क्या होता है, you are having a heart will be having four chambers, right atrium, right ventricle, this is your right atrium, this is your right ventricle, left atrium, left ventricle. First point A, we are starting point A पे I am assuming I am having 120 ml of blood, okay. और second thing I am assuming the mitral valves are closed. These are your mitral valves, जो बीच वाले valves है ये close हो गए, मतलब सारा blood कहाँ पर है, नीचे वाले heart में, all the blood is in the नीचे वाले heart, right. Now what is happening, ये बंद होने की वजह से कौन सा साउंड आएगा, S1 साउंड आएगा। अभी ब्लड तो है लेकिन प्रेशर इतना नहीं है कि पूरी बॉडी में चला जाए, सो वी नीड टू इंक्रीज द प्रेशर, एंड दैट इज नॉन एज आइसोवोल्यूमिक कॉन्ट्रैक्शन। सेम वॉल्यूम पे 120 ml पे ये प्रेशर बढ़ाएगा, कितना प्रेशर बढ़ाएगा, 100 टू 120 mmHg तक बढ़ाएगा। और जब प्रेशर कंप्लीट हो जाएगा, सो व्हाट विल हैपन, अभी इसके अंदर ब्लड है, सो व्हाट विल हैपन, इट विल ओपन अप, इट विल ओपन अप एंड इट विल सेंड द ब्लड टू कंप्लीट बॉडी, ये पूरी बॉडी में ब्लड भेज देगा। देयर विल बी ओपनिंग ऑफ आयोटिक वॉल्व। ओपनिंग से कोई साउंड आएगा, नहीं सर कोई साउंड नहीं आएगा, पैथोलॉजी की बात नहीं कर रहे, फिजियोलॉजिकल, देयर इज नो साउंड। देन देयर विल बी रैपिड इजेक्शन, खोलते ही क्या होगा, पूरा ब्लड तेजी से जाएगा। देन देयर विल बी स्लो इजेक्शन, लेकिन पूरा हार्ट खाली नहीं होता। हाउ मच अमाउंट इज गोइंग आउट, दैट इज योर 70 ml, दैट इज नॉन एज स्ट्रोक वॉल्यूम। आप लोग पढ़ते हो, दैट इज स्ट्रोक वॉल्यूम। व्हाट इज स्ट्रोक वॉल्यूम, स्ट्रोक वॉल्यूम इज नथिंग बट दिस वन इज स्ट्रोक वॉल्यूम, ओके। वट एवर लेफ्ट इज नॉन एज, जो 50 ml बचा है, दैट वुड बी कमिंग बैक। अब ये क्या होगा, धीरे धीरे प्रेशर कम करना पड़ेगा, अदरवाइज व्हाट विल हैपन, अगर इसी प्रेशर में मिट्रल वॉल्व खुल गया, सो व्हाट विल हैपन, द ब्लड विल गो बैक, रिगर्गिटेशन होगा, माइट्रल रिगर्गिटेशन कैन बी देयर, एंड स्टेनोसिस जो अपन पढ़ते हैं, माइट्रल स्टेनोसिस रिगर्गिटेशन, व्हाट इज हैपनिंग, बेसिकली द ब्लड इज गोइंग बैक, बैक फ्लो होता है, राइट। सो व्हाट वी नीड टू डू, वी नीड टू फिजियोलॉजिकली वी आर स्टडिंग, वी आर हैविंग आइसोवोल्यूमिक रिलैक्सेशन। नाउ व्हाट विल हैपन, द प्रेशर विल बी कमिंग टू 50 अगेन, ओके, ये 50 पे आएगा, एंड देन देर विल बी ओपनिंग ऑफ माइट्रल वॉल्व लीडिंग टू normalization of the situation, okay। तो यहाँ पर there is contraction, that is why it is known as systole phase। यहाँ पर सारी phases, isovolumic relaxation, rapid filling, okay, slow filling, protodiastole, all these phases will be here, and that is a डायस्टोल, ओके। इसको सिस्टोल बोलेंगे। सिस्टोल में तीन फेज आएगी, आइसोवोल्यूमिक कॉन्ट्रैक्शन, रैपिड इजेक्शन और स्लो इजेक्शन। दे आर फॉर 0.3 सेकेंड्स, ओके। बहुत ज़्यादा डीप में नहीं जाना है, सिंपल क्वेश्चन, इफ दे आस्क यू, यू हैव टू आंसर सिंपली, ओके। सो दे आर आस्किंग यू इन द फॉलोइंग ग्राफ पॉइंट सी करस्पॉन्ड्स टू, अभी बताओ पॉइंट सी क्या होगा, व्हाट वुड बी पॉइंट सी, स्टार्टिंग फ्रॉम पॉइंट ए। पॉइंट ए पे क्या हुआ, S1 आया, देन देर विल बी आइसोवोल्यूमिक कॉन्ट्रैक्शन, then there will be rapid ejection, then there will be slow ejection, and at point C what will happen, we need to again close, we need to close which valve, blood कहाँ से जा रहा है पूरी बॉडी में, aortic valve में से, so we need to close aortic valve, and due to closure of aortic valve we will be getting S2 sound, simple as that, right। एक बार और इसको देखना, if you are having any doubt you can just rewatch the video and that would be easy for you, okay। so एक बार इसको खुद से बना के देखना, बहुत सिंपल है, okay। Moving on to next question, which of the following point correspond to depolarization of right atrium? Try to answer this, guys. Very good, Cypriya, Rinkesh. Try to answer this one. Sahana. Try to answer this one. Which of the following point corresponds to depolarization of right atrium? Try to answer this. Do you want to understand, or do you want to remember just as it is? Okay, look here. Basically, whenever we will talk about this particular thing, that this is your JVP, jugular venous pressure. Okay, it will be telling us the condition of right atrium. Okay, it will be telling us always the condition of right atrium. Okay, it will be telling us the condition of right atrium. Okay, JVP. So let's see, there are five waves. Okay, there will be two descents. Let's not go into deep. There will be two descent. One is X descent, second one is your Y descent. तीन नीचे जा रहे हैं, three are going upwards, A, C and V. Okay, let's remember as it is. We are having A wave, we are having C wave, we are having X descents, we are having V wave, and we are having Y wave. Okay, what are the things you have to remember? This is a short question, guys. Last time also NEET PG, they have asked this exam, they have asked this question. Okay, FMG also they have asked. Okay, so we are having A wave. A wave is always telling us about the right atrial systole. Okay, right atrial systole. Speak with me. A wave, right atrial systole. A for atrial systole. Okay, A for atrial systole, it's always right. Okay, C, they have asked you about the C wave is due to bulging of tricuspid valve into right atrium during isovolumic contraction. Now you have understood. Okay, so basically just try to understand what is happening. So this is your right atrium, this is your right ventricle. During isovolumic contraction, what is happening? Here is the blood. I told you 120 ml blood will be there, and there will be increase in pressure. It will be increase in pressure. Isovolumic contraction में क्या होगा? 120 ml पे pressure बढ़ेगा. Because of that increase in pressure, what will happen? Here we are having tricuspid valve. So that tricuspid valve will try to bulge into right atrium, and this is what is telling us about the C wave. Okay, so bulging of tricuspid valve into right atrium during isovolumic contraction, that is nothing but your C wave. Okay, descent, try to understand this. X descent will be telling us about the relax. Just remember this. X will be telling us about the relaxation. Next one, V wave is telling us about the right atrial filling, and Y wave, just remember Y for Y, that is rapid emptying due to opening of tricuspid valve. Okay, so we are having A, C, X, V and Y. Okay, A for atrial systole. Revise with me again. A for atrial systole. C is bulging of tricuspid valve into right atrium during isovolumic contraction. They have already asked you this one. Okay. X for relaxation. There is a relaxation where? Always talk about right atrium. Okay. So relaxation in the right atrium. V is atrial filling. V will be filling. So always the filling will be in the right atrium, and Y for emptying. Okay. Emptying of the right atrium. That is all about the JVP. Okay. These are all the JVP. Now let's talk about pathological JVP forms that they have asked you. Simple one-liner you have to remember. If there is absent A wave, that would be your atrial fibrillation. Atrial fibrillation में क्या होगा बच्चों? A wave ही नहीं होगा, A wave होगा ही नहीं. ठीक है? If you are finding large A waves that they have asked you in NEET PG examination, that would be telling us about the pulmonary hypertension or pulmonary stenosis. Pulmonary hypertension or pulmonary stenosis. Tell me the drug of choice for pulmonary hypertension. Okay, next we are having Canon A wave. That would be telling us about the complete heart block or ventricular arrhythmias. Okay, Canon A wave, complete heart block, ventricular arrhythmia. Next we are having large V waves telling us about the tricuspid regurgitation, blood is going backflow. And lastly we are having rise in JVP during inspiration. When we are inspiring, the JVP will be increasing. That is a sign that is known as Kussmaul sign that you will be finding characteristically in constructive pericarditis. Okay, so these are the important things that you should be remembering. Anyone tell me about the drug of choice of pulmonary hypertension? Pulmonary hypertension, guys. Till then, try to solve this question. Which of the following is gold standard for GFR estimation? Okay, which one of the following is gold standard for GFR estimation? कैसे estimate करोगे GFR? How you will estimate that? If you don't know the answer, just mark the inulin, right? Always. So inulin is the right answer, guys. Okay, inulin, we can utilize inulin for the GFR estimation. What is GFR? GFR is basically glomerular filtration rate. Okay, GFR is basically glomerular filtration rate. I would be telling you how to identify that. Okay, para-amino hippuric acid will be telling us about the renal blood flow. Okay, it will be telling us about the renal blood flow. Okay, antipyrine. How do we use antipyrine? Antipyrine is just like water. We can use it for water identification, and Evans blue dye will be telling us about the plasma volume. Okay, pulmonary hypertension, drug of choice, guys. What you are doing? First line, so first of all we can use CCB. Apart from that, if they are not working, we can use endothelin antagonist. एंडोथिलिन आर पोटेंट वैसो कॉन्स्ट्रिक्टर. ओके, बहुत अच्छे वैसो कॉन्स्ट्रिक्टर होते हैं. सो व्हाट वी नीड टू डू, वी नीड टू ब्लॉक दैट. हाउ वी कैन ब्लॉक दैट? वी कैन गिव एंडोथिलिन एंटागोनिस्ट ड्रग्स लाइक bosentan. Okay, endothelin antagonist like drug. Okay, so that would be bosentan. Okay, so we can use those drugs. One more for that is important, that is accidental discovery, that is 5-phosphodiesterase inhibitor, the name of the drug. Now you all must be answering. I really hope you will be answering. That is your sildenafil. That is the drug we can use for pulmonary hypertension. Very good, Rinkesh. Okay, so that is the sildenafil, and the longest acting they have asked you a question, that is tadalafil. Okay, tadalafil. That is a important question. Okay, now let's see how do we identify the levels of blood, levels of different things in the body. So basically, a simple person, for example, my weight is 60 kg. That is not, but if I'm 60 kg person or 70 kg person, how much water will be there, right? For example, my weight is 70 kg, so I would be having 42 liters of water itself, right? 60% will be water. 60% will be water. So that water can be inside the cell, that is intracellular fluid. It can be outside the cell, that is extracellular fluid. It can be between two cells, that is known as interstitial fluid. Okay, it can be between two cells, that is known as interstitial fluid. Inside the cell कहाँ होगा? Either it can be in the nucleus, either it can be in the cytoplasm. ठीक है, यहाँ हो सकता है. ओके, इसके अलावा कहाँ होगा ब्लड? यू विल बी हैविंग वेसल्स. Okay, you will be having vessels, so vessels will be having water in the form of plasma. So total body water, for example, I am having 42 liters of water. Out of that, कहाँ हो सकता है? Either it can be inside the cell, majorly वहाँ होगा. Apart from that, it can be outside the cell, that is extracellular. दो सेल के बीच के फ्लूइड को हम लोग इंटरस्टिशियल फ्लूइड बोलते हैं. एंड वॉट एवर फ्लूइड इज देयर इन द ब्लड वेसल्स, ब्लड वेसल के अंदर सेल्स होते हैं, प्लाज्मा होता है. प्लाज्मा मतलब 92% वाटर होता है प्लाज्मा के अंदर. सो दैट वुड बी योर प्लाज्मा, राइट? So how do we calculate? And they ask you question based on this. So first thing, टोटल बॉडी वाटर कैसे निकालेंगे? पानी जैसा कुछ दे दो. पानी निकालने के लिए क्या करोगे? पानी के जैसा कुछ दे दोगे. दैट वुड बी योर ड्यूट्रियम और ट्रिटियम. ओके, ट्रिटियम, ड्यूट्रियम एंड एंटीपायरिन. हाउ डू यू आइडेंटिफाई एक्स्ट्रा सेलुलर फ्लूइड? वी कैन यूज, मार्क कर रहा हूँ वो भी याद कर लो. वी कैन यूज इनुलिन, वी कैन यूज सोडियम, रेडियो आइसोलेबल सोडियम. ओके, इंट्रा सेलुलर फ्लूइड, हाउ डू वी आइडेंटिफाई? मैंने बताया टोटल में से एक्स्ट्रा माइनस कर दो, दैट वुड बी इंट्रासेलुलर. टोटल में से एक्स्ट्रा माइनस कर दोगे तो क्या आ जाएगा? टोटल में से एक्स्ट्रा माइनस कर दो, दैट वुड बी योर इंट्रासेलुलर फ्लूइड. प्लाज्मा वॉल्यूम already we have solved, that is Evans blue dye. Okay, blood volume, blood will be having RBCs, so we can remember 51 chromium labeled RBCs. Okay, or we are also having a formula, that is 1 minus hematocrit, but we don't use it. Okay, next one is your interstitial fluid. How do we identify? Extracellular निकालो, उसमें से प्लाज्मा को माइनस कर दो, that would be your interstitial fluid. Okay, this is the table you have to see just before your examination and you will be solving the question. Okay, इसमें कुछ भी समझने जैसा नहीं है. Next question. A 30-year-old female patient presented to the OPD with the symptoms of, पहला symptom क्या है? You are the duty doctor, you are sitting in your OPD and the patient is coming to you with the symptoms of, sir, I am having excessive weight gain, I am intolerant to cold, some people cannot sit in AC for longer period of time, right? I am having some menstrual disturbances as well. The diagnosis was made. They have already given you the diagnosis. Maybe they have not given you the diagnosis, right? The diagnosis is Hashimoto thyroiditis. Since it is an autoimmune condition, they've already told you, and the antibodies are formed, right? And antibodies are formed against what? They are asking simple question. Okay, so try to answer. Here, the antibodies are formed against what? Can anyone tell me what is goiter? What is goiter, guys? What is goiter? Goiter क्या होता है? Goiter is due to, all of you know, goiter is due to iodine deficiency, right? Goiter is due to iodine deficiency. Now try to understand what is happening, how it is happening. So we are having hypothalamus will be releasing thyroid releasing hormone, that would be going to, sir, anterior pituitary. It will be releasing thyroid stimulating hormone, and this thyroid stimulating hormone will be going to your thyroid gland, and it will be making T3 and T4. Story is simple and sorted, right? Hypothalamus से TRH निकला, that would be activating anterior pituitary. Anterior pituitary will be releasing what? Thyroid stimulating hormone, and this thyroid stimulating hormone will be going to your thyroid gland and leading to release of T3 and T4. Sir, in T3 or T4 का function क्या होता है? It will be your metabolism. It will be increasing your metabolism. It will be activating your beta 1 receptors also. Okay, so that is the function. Now I asked you what is goiter. Goiter is basically the enlargement, right? So you are having two types of cells in your thyroid gland. We are having follicular cells, we are having parafollicular cells. We are having follicular cells, we are having parafollicular cells. Follicular cells में क्या होगा? They are responsible for making T3 and T4. T3 और T4 कौन बनाएगा? Follicular cells बनाएंगे. Parafollicular will be responsible for calcitonin, guys. It will be having C cells, parafollicular C cells, and that would be responsible for making calcitonin. That would be responsible for making calcitonin. Okay. No, here the answer would be C. Let me tell you guys, just be with me, you will be understanding how it is happening. For example, let's start with the basics. Okay, so what is happening when you are eating something? I will be a little fast. If you guys are comfortable, do let me know. Okay, if not comfortable, do let me know. Okay, so whatever things you are eating, it will be having some kind of iodine. Okay, it will be having some kind of iodine. Now this iodine will be going through your mouth, it will be going to your stomach, GIT, going, ultimately it will be having receptors present on these cells. These are your follicular cells. These are your follicular cells. Follicular cells are present in thyroid gland. Now this iodine will be going inside. This is your iodine. Can you appreciate? This is your iodine. This is going inside with the help of a transporter, that is sodium iodide symport. Now please try to answer me. What is this type of transport? Primary active, secondary active, facilitated diffusion, osmosis, reverse osmosis, whatever you want to answer. Please try to answer what kind of transport is this. That is your NIS, sodium iodide symport. Okay. Now what is happening? Sodium and iodide will be going inside. Iodide is in the I minus form. It is not utilizable. Try to look here, guys. This iodide minus will be going inside the follicle. It will be traveling and it will be coming out in the colloid. This is your colloid. In colloid, what will happen? It will be coming out with the help of a particular gene that is known as pandrid. This is pandrid. Okay, now this iodide minus will be coming outside in the colloid with the pandrid. Understanding? Now what is happening? This iodide is non-utilizable, कोई काम का नहीं है. So it needs to get oxidized first. First thing is your oxidation. First thing will be oxidation. और ये क्या बन गया oxidation के बाद में? It will become iodine. Okay, now when it will become iodine, there will be another step, that is your organification. Okay, organification. And organification में क्या होगा? This iodine will be binding with thyroglobulin. This iodine will be binding with thyroglobulin and it will be making monoidothyroglobulin. If it is binding with single iodine, it will be making diidothyroglobulin when it is binding with 2 iodine. Okay, तो ये organification करेगा. This iodine will be binding with thyroglobulin. Now what will happen? There will be MIT, DIT, MIT, DIT. Now what will happen when monoidothyronine is binding with di? What will happen? Mono plus di, that would be tri. Okay, and when di will be binding with di, that will be making T4, that is your tetrahydrothyrronine, right? So this step is known as coupling. अभी ये क्या करेंगे, सब काम हो गया, आप couple बनाएंगे, right? So they will be making couples, and that would be your coupling, and ultimately they will be making T3 and T4. Now this T3 and T4 will be going again, and it will be stored in the follicular cells. Okay, it will be stored in the follicular cells, and whenever required, this one will be going out. This one will be going out for the functioning. T3 और T4 का function क्या होता है, मेटाबॉलिज्म में काम में आता है, बीटा 1 रिसेप्टर को एक्टिवेट करता है. दैट इज वाई यू आर हैविंग द थायरॉइड स्ट्रोम, राइट? जब आप ये थायरॉइड पढ़ते हो तो वी आर हैविंग अ थिंग दैट इज नॉन एज थायरॉइड स्ट्रोम, एंड द ड्रग ऑफ चॉइस फॉर थायरॉइड स्ट्रोम इज, tell me the drug of choice for thyroid storm. It will be activating beta 1 receptors, right? Beta 1 will be at two places, we have already discussed, right? What will be the symptoms, you will be identifying easily, right? So what is happening, T3 T4 bana liya. Now we are having two things. What I have asked you about the iodine deficiency की वजह से क्या होगा, goiter होगा, right? Simple thing, you told me goiter is due to iodine deficiency, there will be enlargement. What is happening, sir? The information is coming from the brain itself. Look here, we are having thyroid releasing hormone that is coming from hypothalamus. It will be activating thyroid stimulating hormone. Okay, it will be activating anterior pituitary, that would be releasing thyroid stimulating hormone. अब ये thyroid stimulating hormone तो आ रहा है, ठीक है, लेकिन क्या हो रहा है, the problem is we don't have iodine. If there is no iodine, is there any possibility this T3 or T4 can be made? No, there will be no T3 T4. If this pendrid is not working, what will happen, T3 T4 बनेगा, नहीं बनेगा. And all these three reaction, oxidation, organification and coupling, they have asked you the sequence also. Okay, try to remember, first one is oxidation, second one is organification, then there will be coupling. Okay, so all these three reactions are carried out by a single enzyme, that is thyroid peroxidase. Okay, अगर ये enzyme नहीं होगा तो क्या T3 T4 बनेगा, नहीं बनेगा. There will be no T3, there will be no T4. Okay, so ultimately what will happen, there is no iodine. No iodine means what, this will be stimulating anterior pituitary. Now anterior pituitary will be releasing what, thyroid stimulating hormone, and this thyroid stimulating hormone will be going to your thyroid gland. This one will be going to your thyroid gland and continuously stimulating your thyroid gland. It will be telling thyroid gland to make some T3 and T4. And when you are stimulating a muscle or something, a cell, what will happen, either it will do hyperplasia or hypertrophy. You must have studied in pathology. So what will happen, there will be hypertrophy of the cells. But hypertrophy से क्या होगा, is there any possibility T3 T4 बनेगा, नहीं बनेगा, because there is no iodine. Okay, so that is what you are seeing in the cases of iodine deficiency. You will be having goiter. Those people who are having endemic goiter, that means they are living in hilly areas. What is happening, there is no iodine. Because of deficiency of iodine, what will happen, there will be enlargement of the thyroid gland. Understood? Okay, second thing, what are the diseases? Let's find out easily, fast. Okay, if there is no TPO, there will be a disease that we are already studying, that is your Hashimoto thyroiditis. Hashimoto thyroiditis. Okay, very good, that is propranolol, drug of choice for thyroid storm. Okay, Hashimoto thyroiditis, what is happening, there is antibody against this TPO. अगर antibody बन गया तो क्या करोगे, nothing will happen, right? You need to treat this patient. What we need to do, we need to give T4 from outside, that is levothyroxine, we need to give from outside. Altrox, whatever drugs that you are using, that we are giving from outside. Okay, कितना देने, 1 to 1.6 times the body weight. Okay, for example 50 kilo weight है, we will be starting from 0.25 from the day 1, then we are gradually increasing the dose till the time the levels will be normal. ये TSH और T3 T4 का level normal नहीं आ जाता तब तक देंगे, right? We will be discussing in details in medicine. Okay, this is your TPO. Okay, second thing, this is your Hashimoto thyroiditis, most common disease. Out of 5 females, approximately 2 to 3 females are having this particular disease in India, right? In the world itself, right? Second thing is your thyrotoxicosis, also known as Graves disease. Graves disease. यहाँ पर क्या होगा? The story is different here. Here we are also having an antibody. It is also an autoimmune disease. Here we are having what antibodies? We are having LETs and we are having TSI. What is LETs? Long acting thyroid stimulating antibody. and this one is your TSI, thyroid stimulating immunoglobulins. They are thyroid stimulating immunoglobulins. So basically they are stimulating the thyroid gland, and because of that, what is happening, sir, there will be more T4, there will be more T3, and those patients who are having more T4 and more T3, they will be having good metabolism. So there are some people, you must have seen, there are some people who are eating everything, they are eating everything again and again, but they are not getting fat, right? And there are certain people who are not eating anything, still they are getting fat. They will be like, sir, मैं तो पानी ही पीता हूँ, मैं तो पानी ही पीती हूँ, and still I'm getting fat. So those people, it's all about the Hashimoto. By looking at the symptoms, you can easily identify thyrotoxicosis patient will be thin patient, they will be heat intolerant. Just look for the buzzwords, just look for the keywords in the exam. If they have given you a patient with a heat intolerance, that would be your hyperthyroidism patient. Cold intolerant patient, thick patient, chubby patient, okay? Cold intolerant chubby patient, that would be your Hashimoto thyroiditis, or that would be a case of hypothyroidism, okay? Try to connect this story with the things and you will be getting your answer. So here the answer would be thyroid peroxidase, anti-TPO antibodies are there, okay? I think it's clear to now. Do let me know in the chat box if you are understanding this, guys, so that or am I going into too much details? Do you need more details, or you just want to solve the questions? Okay, let's see. Next one is your a 55-year-old male patient presented to you in OPD. Okay, डॉक्टर साहब एक patient आया 55 साल का. He is having complaints of, sir, I am having big pain. Apart from that, I am having some weakness. Okay, I am also having some epigastric pain. Doctor Saab has told me to do some kind of a peripheral smear. मैंने blood दिया था, and in those blood they have found some hypersegmented neutrophils. Okay, they have found some hypersegmented neutrophils. Apart from that, they have done the endoscopy, and in the endoscopy they have find out that the patient is having gastritis, and the patient is on the treatment itself. Patient is on the treatment. Patient is on the treatment. Okay, patient is on the treatment also. So patient is on the treatment, right? Now what we need to do? Treatment क्या होगा? First of all, we are having this case of gastritis, so the patient must be taking PPIs. Okay, patient must be taking PPIs, and remember I told you PPI will be binding with, PPI will be killing what cells? PPI will be killing proton pump. PPI will be killing proton pumps, and those proton pumps, when they are getting killed, it will be releasing two things. I told you about the HCl, plus it will be releasing intrinsic factor. Okay, and this intrinsic factor is like a transporter for vitamin B12, guys. Vitamin B12 get absorbed from ileum. कहाँ से absorb होगा vitamin B12 का absorption? If they ask you, the absorption is from the ileum, but it requires intrinsic factor, and this intrinsic factor is coming from the parietal cell. This intrinsic factor is coming from the parietal cell. So the simple meaning, those people who are taking lots of PPI, what will happen? There will be deficiency of cyanocobalamin, that there will be deficiency of vitamin B12, and vitamin B12 deficiency can manifest as back pain. Along with that, there will be weakness, there will be hypersegmented neutrophils. That is a very important clue that they have given you. Apart from that, you will be finding some tingling sensations in the body, okay, in the extremities. So this is all about the vitamin B12 deficiency. Rest vitamin you will be studying. I'm not teaching you right now, we need to wrap it up, right? Next one is your the V/Q ratio evaluates the matching of ventilation to perfusion. Okay, यहाँ पर क्या दिया है? Ventilation perfusion ratio दिया हुआ है. There is a regional variation in the VQ ratio. Within the lungs, ventilation is 50% greater at the base of the lung than apex. Base में ज़्यादा होगा ventilation. Okay, in healthy individual, V/Q ratio is 1 at the middle of the lungs, and V/Q ratio is 0.03 to 1 from the base to apex. ये vary करेगा. Basically, what it wants to say, try to answer this if you are understanding. Otherwise let me teach you what is that. V/Q मतलब क्या होता है? V is ventilation. The meaning of V is ventilation. डरना नहीं है, इस टाइप का क्वेश्चन बहुत इजी है. V is ventilation and Q is perfusion. Q is perfusion. Ventilation मतलब क्या? Whatever air we are inhaling, whatever air we are inhaling, that is your ventilation. Perfusion मतलब whatever blood is coming there. Okay, that is your perfusion. That is your perfusion. Now what is happening? ये पूछ रहे हैं, the question wants to know when V by Q ratio is infinity. When will be V by Q ratio will be infinity? Try to answer this, guys. V by Q. Ventilation, normal ventilation is 4.2 liters per minute. Perfusion normal is 5 liters per minute. Whatever blood is coming from your heart, that is your cardiac output. Okay, इसको क्या बोलेंगे? Cardiac output. Remember in the last question we have done 70 ml will be your stroke volume. Stroke volume मतलब क्या हुआ? जितना blood गया, जितना blood body में pump कर दिया, that is your 70. Okay, and we are having heart rate of 70, 72. That would be approximately 5 liter. Approximately 5 liters of blood will be thrown by your heart in a minute, and that is known as cardiac output. Okay, that is known as cardiac output. Now we are talking about V by Q ratio. Okay, ventilation, normal ventilation is 4.2 liter per minute. Normal perfusion is 5 liters. So when we get the V by Q ratio, the normal ratio will come around 0.8. इनका ratio approximately 0.8 आता है. Okay, so in the apex of the lung, what will happen? This is my lung. So in the apex, what is happening? There will be more air. Okay, apex में क्या होगा? Air ज़्यादा होगा, perfusion कम होगा. Okay, in the base, what will happen? There will be more perfusion, more blood will be there as compared to air. Okay, so that is why we are having these different values of ventilation and perfusion. Okay, now the question wants to know the V by Q ratio of infinity. When this thing will come infinity? Infinity कब आएगा? जब when you are dividing, this is basically division they wants to know. So when you are making the perfusion 0, when you are dividing ventilation with 0, for example ventilation is 4.2, 4.2 divided by 0, that would be your infinity, right? So they just want to know this simple question, when it will be infinity. So whenever there will be zero perfusion. And what are the situation where you will be finding zero perfusion? Zero perfusion कब होगा इसमें से? Try to answer. देखो, सिंपली परफ्यूजन का मतलब क्या है? ब्लड आ रहा है. नाउ फर्स्ट थिंग, शंटेड ब्लड मतलब क्या हो गया? देर इज नो ऑक्सीजनेशन, देर इज नो ऑक्सीजन इन द ब्लड. सेकेंड थिंग, एम्फाइसीमा व्हाट विल हैपन? देर विल बी प्रॉब्लम विद एयर, देर विल बी प्रॉब्लम विद वेंटिलेशन. ओके, फॉरेन बॉडी ऑब्स्ट्रक्शन, देर विल बी प्रॉब्लम विद द एयर अगेन. बट पल्मोनरी एम्बोलिज्म होता क्या है? पल्मोनरी एम्बोलिज्म, दिस इज अ पल्मोनरी वेसल. नाउ व्हाट इज हैपनिंग? There is some kind of a blockage here, and because of that blockage, what is happening? There is no blood coming forward or backward, right? So what will happen because of that blockage? Suppose here we are having some alveoli. Is there any possibility the gas exchange will occur? No, because it is already getting blocked here, right? Because of that there is no blood coming. और अगर ब्लड नहीं आएगा तो ऑक्सीजनेशन कहाँ से होगा? नहीं होगा. सो दैट वुड बी योर pulmonary embolism, right? So answer here would be pulmonary embolism. Let's see what are the different things we have to remember here. 0.8 ratio we will see in the lungs, that is 4.2 divided by 5 ventilation by perfusion, that is the normal thing. V by Q ratio will be more in the apex because ventilation will be more in the apex. Okay, and that is the reason why mtb is a aerobic bacteria. Okay, it requires oxygen, so it will be growing in apex regions. Okay, second thing, V by Q ratio will be low at base. Okay, because there is low ventilation and high perfusion. Okay, V by Q ratio 0. They can ask you this particular question now for making it 0, what we need to do? We need to make the ventilation 0. Okay, इसको 0 बनाने के लिए क्या करना होगा? V by Q 0 करने के लिए V को 0 कर दो. If V is 0 and ventilation perfusion is 5, what would be your answer? That would be your 0. Okay, so what are the situation when you are having no oxygenation, no oxygen in the lungs, right? So first one will be shunted blood, second one will be emphysema, third one will be foreign body obstruction. ऊपर से ही बंद कर दिया, right? Second thing, V by Q ratio will be infinity at two things. One is pulmonary embolism, second one is dead space. If you don't understand the concept, just remember this particular thing. Okay, because in little time we cannot go in more details. Okay, I'm trying to explain as much as possible, right? Next thing, please try to identify the sleep wake marked in the EEG during the sleep wake cycle. What is this particular thing that you are seeing here? This is about the sleep. And can you appreciate, can you tell me how many types of sleep do we have? Arvind wants with detail. Yes, we are going in a little bit detail also. I think we will be able to complete most of the questions. Okay. Otherwise, we can have a part two as well. Okay. Identify the sleep wake marked in the EEG during the sleep wake cycle. So this is a sleep spindle. This is a sleep spindle with K complexes. Now you can answer sleep spindle with K complexes you are seeing basically in which phase of sleep? That is an REM2. That is an REM2. You will be finding sleep spindle with K complexes. Try to understand this. Okay, how many types of sleep wake cycles? Let me discuss here. So for example, you guys are sitting in front of me, and we are studying. So in the first half, in the starting, what will happen? You guys are awake, you guys are alert, your eyes are open. So you are in the beta wave. Okay, in your brain there will be beta waves going on. Now what is happening? The questions are getting difficult, and now still you are looking at the video, and you are still quiet, you are awake, but still your eyes are getting closed. So that would be your alpha waves. Okay, after sometimes after 9:30 or 10, what will happen? You will be having a loud light sleep, and you will feel like drowsy. That would be your theta waves. And ultimately, you know what happens? You will be sleeping with me. So that would be your delta waves. Okay, so lastly we will be having delta waves. Okay, lastly we will be having delta waves. And I am in which wave? I am in the gamma wave, guys. Okay, gamma wave means I am in the focused attention. Gamma waves will be seen in focused attention. For example, those people who are doing like meditation and all those things, they will be having this type of gamma waves. Okay, so beta will be awake and alert. Okay, alpha will be quiet. Okay, awake, eyes closed and quiet. Theta will be a little drowsy. Okay, and deep sleep will be delta. D for D, delta. Delta will be sleeping patient. Okay, now we are having an REM1. In an REM1 we are having theta waves. And REM2, that is important question, they have asked you multiple times based on image as well. That is your sleep spindle with K complex. And REM3 and 4 you will be finding in the deep sleep. Okay, next one is your NREM disorders. So NREM मतलब क्या होता है? NREM मतलब non rapid eye movement. Okay, non rapid eye movement, but you have to remember simple thing: non remembering. Whatever you are seeing in the NREM you will not remember. REM मतलब में REM is rapid eye movement, but whatever things are happening you will be remembering. So there are some disorders. First one is your sleepwalking. Those people who are walking in the sleep, they are known as somnambulism, right? Second thing is your sleep talking, that is known as somnolique. Okay, bruxism का मतलब क्या होता है? What is the meaning of bruxism? You will be having teeth grinding. Teeth grinding is known as bruxism. And nocturnal enuresis. Tell me the treatment of choice and drug of choice for nocturnal enuresis. That means those patients will be having those patients who are urinating in the night itself, right? That is known as nocturnal enuresis. And then we are having night terrors and nightmares. So what is the difference? The night terrors, the baby is sleeping and he will be just waking up, and he was like, sir, I have a bad dream. So when the parents try to ask what was the dream, they don't know anything because it is in the NREM. I told you it will be not remembered. Okay, sometimes you are having a dream, you just wake up and you don't remember anything. So that is your NREM sleep. Okay, when you are having a dream, that is you generally say like that is the worst nightmare of my life. Okay, तो वो क्या होता है? वो nightmare is something that you remember. Nightmare is in the REM sleep. सपने दोनों ही sleep में आते हैं. They ask you the question, you will be having dreams in which phases? NREM में भी होगा, REM में भी होगा. Okay, NREM में भी होगा, REM में भी होगा. नार्कोलेप्सी में क्या होता है? आदमी सो जाता है, right? So we can give methylphenidate, we can give amphetamine like drugs. Okay, modafinil, all those things. Okay, so these are the things. Yes, the drug of choice for nocturnal enuresis will be desmopressin. Okay, and the treatment of choice will be bad alarms, and we can also give motivational therapies, right? So that would be the this question. Okay, next, try to answer this question: which substance is working on point A? यहाँ कौन सा substance काम करेगा? This is the exact question they have given you. Acetylcholine, VIP, substance B. First of all, try to identify the motility, which is this motility, guys. मोटिलिटी होती है जीआईटी के अंदर, दिस इज योर पेरिस्टालसिस, लेट मी टेल यू, दिस इज योर पेरिस्टालसिस. एंड इफ आई आस्क यू द क्वेश्चन व्हाट इज द डोमिनेंट मोटिलिटी दैट यू विल फाइंड इन योर जीआईटी. जीआईटी में बहुत सारी मोटिलिटी होती है. यू विल बी हैविंग इलेक्ट्रिकल, मैकेनिकल मोटिलिटीज. सो यू आर हैविंग मास मूवमेंट, you are having segmentation, multiple things are there. So tell me the answer, what is the dominant motility that you will be having in your GIT? Till then I'm telling you about this. So here we are having contractile segment, we are having relaxing segment. So food आगे क्यों जाता है? Peristalsis मतलब क्या होगा? The food will be going in the forward direction always. Reverse peristalsis, that is vomiting, what will happen? The food will come in the backward direction. That is a different case scenario. But normally what will happen? The posterior segment will contract and the anterior segment will dilate. And this is because of certain neurotransmitter, that is contraction is due to acetylcholine and substance P. Remember guys, contraction is due to acetylcholine along with the substance P. Okay, that is why acetylcholine increase the contractility of the GIT, that is parasympathetic rest and digest. Means क्या हुआ? Acetylcholine बढ़ गया. Second thing, relaxation. Always remember, just like I told you about the somatostatin, it is always inhibitory. Nitric oxide will always be dilatory. It will be causing relaxation. So first one is your nitric oxide and second one is your VIP. Very important person, that is vasointestinal peptides. Okay, so these are the two important things that is causing dilation, and these are the two important things that is causing contraction. Now important thing, point A, which thing is working? So that would be your answer, that would be your B. Okay, apart from that, when you try to look at this motility, this is your segmentation guys, this is your segmentation. And remember, they have asked you a question and there is high probability they can ask you this particular question again, that segmentation is the dominant motility in the GIT. They will ask you the question, what is the dominant motility in the GIT? सबसे ज़्यादा क्या होता है? The answer will be segmentation. Look here guys, what is segmentation? क्या होता है? Peristalsis cannot be the answer, because peristalsis अगर होगा, so what will happen? Peristalsis फटाफट होगा तो खाना फटाक से बाहर चला जाएगा, right? So what is the dominant motility? That is a segmentation. Look here, the same segment will be contracting, the same segment will be dilating. Look here, try to understand this. Look at this particular point. What is happening? This is the point where the things are there is contraction. Now what is happening? The same point will be relaxing. Again what is happening? The same point will be contracting. So it will be working like that. Okay, it will be working like that, and it is helpful in digestion of the food, right? So function, ये जो bolus है, look here, this bolus is getting converted into small particles. And what is digestion? Digestion is basically the conversion of larger particle into small particles. क्या करना है ultimately? रसगुल्ला खाया, उससे क्या बनाना है? ग्लूकोज बनाना है, right? So this is how they are making the glucose. And the dominant motility in GIT would be your this one. MMC क्या होता है? What is MMC? That is migratory motor complex guys. MMC is migratory motor complex. Okay, ये the question that they have asked you about this, where does it start? It start from the mid part of stomach, and it will be ending to terminal ileum guys, terminal ileum. Okay Rinkesh, terminal ileum तक जाएगा. So what is MMC? When you guys are hungry for a longer period of time, you know what happens? There is a strong wave of contraction that is generated in your GIT. Okay, ऐसा आवाज आता है ना, बोलते हैं कि पेट में से आवाज आ रहा है. So what is that? That is nothing but your MMC. You know what happens in MMC? There is a strong wave of contraction that is generating when you are hungry for a longer period of time. Okay, इससे क्या होगा? The function will be cleaning. Whatever remnants is left behind, the function will be cleaning of your GIT. जो भी चीज़ें बच गई है ना, उसको क्लीन करके एंड तक ले जाने का फंक्शन है. दैट इज योर माइग्रेटरी मोटर कॉम्प्लेक्स. दिस इज द मोटिलिटी. दिस इज अ टाइप ऑफ mechanical motility, but this one will be seen in fasting stage. Okay, segmentation will be seen in fed state. Okay, and this one peristalsis is also seen in fed state. We are also having electrical motility, basal electrical rhythm, all those things. Okay, so इतना पढ़ लो भी, ठीक है. Next one is, which of the following junction is helping the cell to bind with the basement membrane? Okay, कौन से सेल्स है जो बेसमेंट मेम्ब्रेन से जोड़ने में मदद करते हैं? व्हाट आर द सेल्स दैट आर बाइंडिंग दिस थिंग टू basement membrane? Try to answer this one. Till then I'm explaining you. So we are having different type of cells. जो cells होते हैं, they are binded together and they are binded with the basement membrane itself. Okay, ये दो चीज़ों से जुड़े होते हैं. I have already dermatized you. Okay, we will be discussing day after tomorrow. Okay, we will be discussing in derma. We are having tight junctions, we are having adherent junctions, we are having desmosomes, gap junctions and hemidesmosomes. Okay, so what are tight junctions, guys? Tight junction में क्या होगा? They are closely attached. Okay, two important thing you have to remember, direct question, claudin and occludin. Claudin and occludin are two proteins that are making the tight junctions. Two cells are closely binded together, and this claudin and occludin, they are present in your blood-brain barrier. First thing, blood-brain barrier. Second is your blood-testis barrier. Okay, blood-testis barrier और सर्टोली सेल की वजह से होता है. There you will be finding these tight junction. Tight junction, claudin, occludin. First thing. Second thing, adherent junction. Adherent junction में क्या होगा? There will be actin. Just in case, there will be actin. Adherent junction will be actin. Desmosomes, we are having desmosomes. Two cells are binded together with the help of desmosomes. They are present in stratum spinosum, and if there is mutation of desmosomes, we are having desmoglein, desmoplakin, desmocholine, right? If there is mutation of desmoglein, what will happen? There will be a disease known as pemphigus. Okay, pemphigus. Desmoglein 3 का होगा तो that would be vulgaris, 1 का होगा तो that would be foliaceous. Okay, then we are having gap junctions, and I have told you maximum gap junctions are present in your cardiac muscles. Okay, they are made up of connections. They are made up of connections, and maximum gap junctions are present in your cardiac muscles. And if there is mutation of these gap junctions, you know which disease will occur? That is your Charcot-Marie tooth disease. Mutation will lead to Charcot-Marie tooth disease. Okay, apart from that, lastly we are having hemidesmosomes. Two cells are binded together. Now they need to bind to basement membrane. Okay, they are binded with the help of hemidesmosomes. Hemidesmosomes की वजह से जुड़ेगा, and we are having two proteins, important ones. We are having multiple plectin integrin, BPAG1, BPAG2. So these are important. Just remember bullous pemphigoid antigen. So what is the disease that will occur here? That is your bullous pemphigoid. Bullous pemphigoid is the disease that will occur here, right? There will be deposition of IgG linear pattern you will be seeing in pemphigus. You will be seeing which pattern? Fishnet pattern. Okay, so this is your pemphigus disease. You will be having two cells will be separated. Okay, this one is your pemphigus. All of these are pemphigus, and this one is your bullous pemphigoid. Okay, bullous मतलब बुल्ला मतलब क्या होता है? Fluid filled lesion. So you will be finding this type of lesions. Okay, this one is your Charcot-Marie tooth disease. So these are the important pointers that you should be remembering about them, right? So what would be the answer? Very nice, Rinkesh. So that would be C would be the answer. That is your hemidesmosomes. Hemidesmosomes. Okay, अभी समझ में आया क्यों नहीं होगा बाकी? Okay, now try to answer this. ECG is recorded with phonocardiogram. Right now they are asking question based on this. To identify the different heart sounds are given below. At ECG point A, they want to know at point A which sound will be heard. Okay, so I will be giving you a simple mnemonic. Let's not go into details. Okay, so the simple mnemonic is RTP. Revised TB program you can remember. So simple mnemonic is RTP. At the peak of R wave you will be finding S1. At the end of T wave you will be finding S2, and there will be S3. That would be, sorry, S4 will be there. That would be your S4. Okay, that you will be finding at the end of P wave. So you can remember these three with the help of this mnemonic. That is RTP. Okay, peak of R wave, look here, S1 you will be here finding at the peak of R wave. S2 you will be finding at the end of T wave. That is your S2. S3 will be finding after rapid filling phase, and S4 you can remember with the help of this P, that is end of P wave. Okay, so you can remember directly, and now you can answer this particular question. This is peak of R wave. So which sound can be here? So that is your nothing but S1. Okay, that is your S1 sound. Okay, clear? Try to answer this. Impaired function of aquaporin causes which of the following? So first of all, aquaporin is a type of primary active, secondary active, facilitated diffusion. What is that? Aquaporins. They will be utilizing energy or not? Try to answer this. A, nephrogenic. Okay, let's try to understand this. What is diabetes insipidus? Okay, what is aquaporin? and just try to understand it completely. Okay, I'm going fast. Hypothalamus will be releasing two hormones. These are your which hormones? Wo hormones. Okay, V4 vasopressin, very important information. O4 oxytocin, guys. Vasopressin and oxytocin, they are formed in hypothalamus. Remember, very important information I am giving you. Formed in hypothalamus, and they will be going and stored in posterior pituitary. They will be going and stored in posterior pituitary. I don't know why it's not working. They will be going and stored in pituitary posterior pituitary. Okay, so posterior pituitary, if they ask you posterior pituitary forms which hormone, it will not form any hormone. It will be storing which hormone? वो वाले हार्मोन. कौन से हार्मोन स्टोर करेगा? वो. वैसोप्रेसिन का दूसरा नाम होता है, व्हाट इज द अदर नेम ऑफ वैसोप्रेसिन? That is your antidiuretic hormone, right? Antidiuretic hormone. It will be having how many receptors? It will be having three receptors. We can remember V1, V2, V3. V1 is present on vessels, so it will be causing vasoconstriction. V2 will be present in your aquaporins, okay, and V3 is responsible for increasing the ACTH, okay. So these two are important. Now what is happening? What is diabetes insipidus? What will happen? So this antidiuretic hormone will be coming and binding to this V2 receptor, okay. Impaired function of aquaporin. These are the impaired function of aquaporin. मतलब problem कहाँ है? Where is the problem? Hypothalamus is working very fine. Hypothalamus is releasing vasopressin or ADH. It is going to store in the posterior pituitary. It is going to work on the kidney itself, but these receptors are not working. And if these receptors are not working, then we call this disease as nephrogenic diabetes insipidus. मतलब सिंपल में समझो ये होगा, ADH कम हो गया, that is diabetes insipidus. Okay, ADH कम हो गया, that is diabetes insipidus. It can be nephrogenic, it can be central. Central में क्या होगा? What will be there in the central? Central means the problem lies in the either in the hypothalamus, either in the pituitary. That means receptors are working fine, but the problem lies in the hypothalamus or pituitary. Okay, so that is all about it. अगर इसका लेवल बढ़ जाता है, if there is increase in the levels of ADH, what do we call it? That is syndrome of anti appropriate diuretic hormone, right? यहाँ पर you will be finding dilutional hyponatremias, all those things, and the drug of choice will be conivaptans. Drug of choice will be conivaptans. Okay, drug of choice will be conivaptan. Okay, and for diabetes insipidus nephrogenic, the drug of choice will be thiazides, and for central the drug of choice will be desmopressin. Just like vasopressin का भाई है desmopressin, we can give desmopressin. Okay, yes, we can talk about it. We will try to cover up everything here itself. I think we can do it. Okay, Gitelman syndrome. Gitelman syndrome is due to there is mutation in Gitelman syndrome is due to mutation in DCT. There is a pump that is known as sodium chloride pump. Okay, sodium chloride pump. And Bartter syndrome is due to mutation is sodium potassium 2 chloride pump. Okay, Bartter syndrome is due to mutation in sodium potassium 2 chloride pump, जहाँ पर आपका loop diuretics काम करता है. Okay, so let me summarize everything for you. Okay, so please try to be attentive for next 5 to 10 minutes, and you will be understanding how it is happening. Okay, look here. So basically you are having your हार्ट में मैंने तुमको बताया था कार्डियक आउटपुट. लेट्स अंडरस्टैंड वॉट एवर वी हैव स्टडीड. सो कार्डियक आउटपुट विल बी 5 liters. Okay, out of that 5 liter blood, how much is going to your kidney? So that would be 20% of that 5 liter, that would be 1 liter. Try to remember this. Okay, 1 लीटर किडनी में गया, 5 लीटर दिल से बाहर आया. Okay, so 1 liter will be having two components. Blood will be having cells, blood will be having plasma. Cells will be there, plasma will be there, right? How much is the cells? Sir, 40% will be cell, 60% will be plasma, right? So out of that 1 liter, 600 ml will be plasma. Fine. Out of this plasma, only 20% will get filtered. Only 20% will get filtered. And how much is that? 60 600 का 20% कितना होगा, 10% हो गया 60, 20% हो गया 120. So that would be your 120 or 125 ml. That would be your GFR. What is that? GFR. So that means whatever blood is coming to your heart. Try to understand this. Whatever blood is coming from your heart, that would be going to your kidney, and in your kidney, how much is getting absorbed, filtered, that is known as GFR, that is known as glomerular filtration rate. समझ में आया बच्चे? ठीक है. Now what will happen? ये 125 ml will be GFR because cells will not get filtered. RBC, WBC, platelets filter नहीं होंगे. अगर RBC blood में आ रहा है, that is a pathology. Okay. Only plasma proteins भी filter नहीं होंगे. Only plasma, the water will be getting filtered, right? Out of this 125 ml, please try to answer how much is the urine output in a day. Urine output in a day. How much urine you will be excreting in a day? How much urine? So that would be approximately 1500 ml, dead liter, right? And in a day you will be having 1440 minutes. So that means you will be making approximately 1 ml unit per minute, right? And the GFR is 125 ml. Now where is that 124 ml is going, right? That will be reabsorbing again. That will be reabsorbing again. Try to understand that out of that 5 liter, only 20% will be going to kidney, and out of that 20%, only 20% get filtered. That would be your GFR. And now this GFR, out of this GFR, only 1 ml urine is coming out in a minute, right? That is how you will be having 1.5 liter in a day. Okay. If it is less than 400 ml, we call it oligouria. If it is more than 3 liter, we call it polyuria, right? So these are the important things. Okay. Now what is happening? What is happening with that urine? That is what we need to remember. Okay. This one is your proximal part. This is coming in the earlier part, proximal. It is looking like a convoluted. So that is your proximal convoluted tubule. Then there will be loop of Henle, thick and thin parts, then thin and thick parts. Apart from that, there will be distal region. This is your distal, again this is convoluted. This is your distal convoluted tubule. Going to your collecting ducts. Collecting ducts will be having upper part and lower part, and upper part will be having different cells, lower part will be having different cells. Okay. So I'm just giving a brief info that 65% of the fluid will be reabsorbed in the proximal convoluted tubule. 25% will be reabsorbed here in the loop of Henle. 6 to 8% will be reabsorbed here in the distal convoluted tubule, and collecting duct we are having 2 to 3% reabsorption. Okay. So this is how only 1 ml of urine will be coming out, and that urine will be coming via ureter, and it will be going to your urinary bladder, and that would be going to your urinal, right? So this is the complete story of the urinary system. Okay. What are the drugs that you can utilize? For proximal convoluted tubule, there is a pump that is known as carbonic anhydrase. You can use acetazolamide. Okay, here we can use loop diuretics. Here we can use thiazides and DCT, and then we are having potassium sparing diuretics like spironolactone, aplerenone, okay, amiloride, or those things. Okay. So this is a brief story about PCT. Important things you need to remember. One more thing that you need to remember: 100% of sugar and amino acid will be reabsorbed from the PCT. Second thing, if there is mutation of this particular pump, this is your loop pump, loop diuretics are working there, that would be causing Bartter syndrome. DCT mutation will cause Gitelman syndrome. Okay, here we are having sodium chloride pump, thiazides will work here, calcium will get reabsorbed here. There is a pump that is known as TRPV5, transient receptor vanilloid protein 5, and lastly we are having two cells here. The above part will be having cells for, these are your principal and intercalated cells. Okay, where aldosterone will work, and here in the lower part we are having V2 receptor that I told you about, the anti-diuretic hormone that would be working in the lower part. Okay, so these are the cells. Here you can be having SIADH or another syndrome, that is diabetic insipidus. Okay, two things can happen here. Okay, here aldosterone you can have multiple things. Okay, let's discuss. Next question: which hormone plays a permissive role in puberty? Which of the following hormone plays a permissive role in puberty, guys? Try to answer. So basically, what is puberty? How it is happening? Try to understand this. Puberty is due to gonadotropin releasing hormone GnRH that is coming from your hypothalamus. That would be going to your anterior pituitary, और anterior pituitary से क्या release कराएगा बच्चों? It will be leading to release of LH and FSH. क्या रिलीज करवाएगा? LH और FSH. This LH and FSH will be going to your gonads and that would be producing different things, right? Estrogen, progesterone, सारी चीजें यहाँ से आएगी, ठीक है? So basically what is happening before puberty, this pulsatile release of GnRH is inhibited by GABA. Okay, first thing, let me teach you. Whenever we are having a pulsatile release, for example, I'm coming to you on a constant interval after 10-15 days, what will happen? You will be positively stimulated by me. अगर मैं 15 दिन में आके मोटिवेट करूंगा, you will be understanding. But if I am giving continuous release means मैं रोजाना सुबह आके तुमको बोलूं, what will happen? You will not listen to me. Okay, your receptors will get desensitized. Okay, this is what it is happening in the body itself. We are all same, right? So pulsatile release of GnRH is inhibited by GABA. Okay, GABA का function always inhibitory, somatostatin always inhibitory, nitric oxide vasodilatory, GABA always inhibitory. Okay, so जो pulsatile release होता है वो बंद हो रखा होता है किसकी वजह से? GABA की वजह से. Now what will happen around the time of puberty? A hormone will release that is known as kisspeptin. Okay, ये हार्मोन kisspeptin निकलेगा and this kisspeptin will go and inhibit this GABA, and when this GABA is getting inhibited, what will happen? There will be pulsatile release of GnRH, और pulsatile release से क्या होगा? LH बढ़ेगा, FSH बढ़ेगा, and there will be puberty. That is the simple story. Okay, ये ब्लॉक किसकी वजह से हो रहा है? GABA की वजह से. ये कब हटेगा ब्लॉक? This block will be removed when there will be puberty. Now how the body will get to know? कि अभी puberty आ गया. तो ये कैसे पता चलेगा? With the help of a important thing that is leptin. Okay, and this is the question they have asked you. Leptin plays a permissive role. Leptin बताएगा बॉडी को कि अब किस पेप्टिन रिलीज करो. किस पेप्टिन की वजह से क्या होगा? गाबा हट जाएगा. गाबा हटने की वजह से क्या होगा? पल्सेटाइल रिलीज होगा. उसकी वजह से क्या आ जाएगा? प्यूबर्टी आ जाएगी. pulsatile release will lead to puberty. Okay, now this leptin is responsible for adequate fat storage. leptin किसके बारे में बताएगा? It will be telling us about the adequate fat storage. For example, some girls are very thick, right? कुछ लड़कियां मोटी होती हैं. They will be having a disease that is known as precocious puberty. कुछ लोग some mothers are feeding their children too much. Because of that, what is happening? एडिक्वेट फैट स्टोरेज है. फैट ज़्यादा बढ़ गया जल्दी. फैट ज़्यादा बढ़ गया तो क्या होगा? लेप्टिन जल्दी आएगा. लेप्टिन जल्दी आएगा तो क्या होगा? किसपेप्टिन जल्दी हट जाएगा. किसपेप्टिन जल्दी हटेगा तो क्या होगा? व्हाट विल हैपन? गाबा हट जाएगा. गाबा हट जाएगा, देयर विल बी प्यूबर्टी, एंड दिस टाइप ऑफ प्यूबर्टी इज नॉन एज प्रीकोशियस puberty. Okay, in some people who are like there is not enough food, those people, कुछ लोग ऐसे होते हैं जिनको खाना नहीं मिल पाता. They are thin people, right? Now what will happen? Leptin will come later. leptin नहीं आएगा, लेट आएगा तो क्या होगा? kisspeptin भी लेट आएगा. There will be constant stimulation by GABA, and ultimately you know what happens? They will not be having LH, FSH और puberty नहीं आएगी. That is known as delayed puberty. Okay, treatment you will be studying in pharmacology, that is your leuprolide, cetorelix, all those things. Okay, we can remember that, तो वहाँ जाके देख लेना. But this is the basic concept. Okay, now the question they have asked you, which of the hormone plays a permissive role in the puberty, and the answer would be leptin, guys. Okay, leptin. Prolactin का function क्या होता है? The function would be production of milk. Milk ejection is due to try to answer, that is due to oxytocin. Okay, GnRH function we have already seen, right? Insulin we will be studying now. Okay, now this is an important question. Right shift of the oxygen hemoglobin dissociation curve is due to. Right shift कब होगा? This is a question they have asked multiple times. Try to understand this. Simple things are here. Okay, इसको simply समझ लो. What will happen? Okay, so first thing you have to tell me, what is the function of hemoglobin, guys? What is the function of hemoglobin? Hemoglobin का function क्या होता है? Hemoglobin का function होता है, sir, it will be binding with the oxygen and it will be helping in the transport of oxygen. Okay, HPO2 को ये लेके जाएगा and it will be transporting to various organs. Okay, so now what will happen? Look here, whenever we are talking about right shift of the curve, right shift of the curve, there will be release of oxygen from hemoglobin. If you understand this, life will be easy. Okay, so hemoglobin किसके साथ में bind हुआ है? Generally it is binded with the oxygen. Now in right shift, just remember R for right shift, R for release of oxygen. Okay, now this oxygen is getting released from hemoglobin, so that means unloading of the oxygen. And when do we need oxygen? कब चाहिए होता है oxygen? जब बॉडी में हाइपोक्सिया होगा. व्हाट इज द कॉज फॉर दैट? दैट इज हाइपोक्सिया. हाइपोक्सिया का मतलब क्या होता है? कार्बन डाइऑक्साइड ज़्यादा हो गया. एंड कार्बन डाइऑक्साइड और H प्लस दोनों भाई भाई है, ऐसे याद रखो. ठीक है, तो राइट शिफ्ट ऑफ द कर्व कब होगा? राइट शिफ्ट का मतलब है रिलीज ऑफ ऑक्सीजन. तो ऑक्सीजन कब रिलीज होगा? जब ऑक्सीजन की ज़रूरत होगी. ऑक्सीजन की ज़रूरत कब होगी? दैट इज नॉन एज हाइपोक्सिया. हाइपोक्सिया को हम लोग क्या भी बोल सकते हैं? हाइपर कार्बिया. जब भी CO2 बढ़ गया, दैट इज हाइपोक्सिया बेसिकली. और CO2 और H प्लस भाई भाई है. CO2 बढ़ेगा, H प्लस हमेशा बढ़ेगा. ठीक है, तो H प्लस के बढ़ने को क्या बोलते हैं हम लोग? fall in pH, right? And that is what is known as acidosis. Okay, now we understood. So whenever there is increase in the PCO2, whenever there is increase in the H plus, whenever there is increase in the temperature, जब भी CO2 बढ़ेगा, जब भी hypoxic condition होगी, what will happen? There will be right shift of the graph. Right shift of the graph. Simple. नहीं समझ में आया पूछ लेना. Okay, so wherever there will be release of oxygen, there will be a right shift of the graph. Okay, अब ये acidosis भी हो सकता है. It can be due to fall in pH. They can write increase H plus, they can write increase in temperature. Okay, they can write multiple things. Okay, second thing, and this effect is known as Bohr effect. This effect is known as Bohr effect. R for R याद कर लो. R for R, right shift. Right shift is due to release of oxygen, and that would be causing which effect? Bohr effect. Okay, second thing, unloading कब होगा? When there will be unloading of oxygen. Look here, left shift of the graph will be seen in the cases when there is hemoglobin plus oxygen, ये bind है. Now it does not want to give oxygen. Now it is not giving oxygen. That means there is increase in oxygen. Oxygen पहले से ही ज़्यादा है. Decrease in CO2. Condition can be decrease in CO2 और there can be decrease in H plus. CO2 कम हो गया तो H plus भी कम हो गया. H plus कम हो गया मतलब कौन सा सिचुएशन हो गया? एल्कलोसिस हो गया. ठीक है, H plus बढ़ गया तो एसिडोसिस, H plus कम हो गया तो एल्कलोसिस. So there will be decrease CO2, decrease H plus, decrease temperature and fetal hemoglobin also. Okay, एक दो पॉइंट एक्स्ट्रा याद करने, but I think you have understood by now how to use this. Okay, so बस थोड़ा सा एक कॉन्सेप्ट याद रख लो, life will be easy for you. Okay, the graph will be sigmoid graph और इस इफेक्ट को बोलते हैं Haldane. Okay, unloading L for Haldane. L, just remember like that. That is your Haldane graph. Understood this? Let me know if you are understanding. Okay, next question, identify the pattern of breathing given below. Okay, identify the pattern of breathing given below. क्या कौन सा pattern है? Just look here, what is happening? Just try to understand this. First thing, this is your normal apnea. Now what is happening? Gradually there is hyperapnea followed by hypoapnea. फिर उसके बाद में फेज आएगा एपनिया का. देन देर विल बी हाइपर एपनिया, देन देर विल बी hypoapnea. There will be gradual hyperapnea, then there will be hypoapnea, there will be pause, then there will be hyperapnea, hypoapnea, and then there will be pause, right? So this is known as chain stroke breathing. This is known as chain stroke breathing. How to identify these breathing patterns? Look here. So first one is here, this is your normal inspiration expiration. This is the tidal volume that we are inspiring and expiring, that is 500 ml. Okay, this is your normal respiration. Second thing, Biot's respiration. You know what happens in Biot's respiration? There will be hyperapnea. There will be hyperapnea followed by an event of apnea. Then there will be again hyperapnea. ठीक है, hyperapnea होगा, फिर एक बार रुकेगा, सांस रुकेगी, then again you will be having hyperapnea. Okay, कुसमूल में you will be having hyperapnea episodes. Okay, Kussmaul, when you will be finding Kussmaul breathing in diabetic ketoacidosis, try to understand what will happen in diabetic ketoacidosis. Simple concept that we have studied in the last slide. Acidosis हो गया मतलब क्या हो गया? CO2 बढ़ गया. CO2 बढ़ गया lungs के अंदर, तो what we need to do, we need to throw it out. So those patients who are having diabetic ketoacidosis, they will just try to excrete the CO2 out, and that type of breathing pattern is known as Kussmaul breathing. Any type of acidosis, whenever there is hypercarbia in the lungs, जब भी CO2 बढ़ेगा क्या करेगा पेशेंट, हाइपरवेंटिलेशन करेगा. दोज पेशेंट्स हु आर गोइंग इनटू like mountains, acetazolamide हम लोग देते हैं, right? Mountain sickness, what is happening, there will be hyperventilation. What the patient will try to do, he will try to hyperventilate to decrease the CO2, right? Next thing is your chain stroke breathing that we have already seen. Gradual hyperapnea होगा, फिर hypoapnea होगा, then there will be apnea. एक बार ये देख लेना, you will be understanding. This type of breathing pattern you will be finding in congestive heart failure. This is very very characteristic of DKA patient, diabetic ketoacidosis. Medulla में अगर damage है, you will be finding Biot's breathing pattern, and this is the normal thing that you will be seeing, right? So you can easily identify this is your chain stroke breathing pattern. Okay, now try to answer this. Pain and temperature is carried out by which tract? पेन और टेम्परेचर कौन से ट्रैक्ट लेके जाएंगे? जस्ट रिमेंबर लैटरल. लैटरल मतलब आई थिंक यू मस्ट हैव नोन दिस. लात पड़ेगी तो क्या होगा? पेन होगा. लात पड़ेगी तो क्या होगा बच्चों? पेन होगा. there will be temperature, there will be increased pain, there will be increase in the temperature. That is the lateral spinal tract. Okay, anterior में क्या होगा? आंटी का टच कैसा होता है? The touch of auntie will be crude. Aunt or aunt, crude touch or fine touch with pressure. Crude touch or pressure, right? Next one, dorsal column pathway. It is for the fine touch and proprioception. Along with fine touch. Okay, spinoreticular. Let's see one by one how they are working. Okay, how they are working. So we are having this hemisection. This is the cross section of the spinal cord. I have cutted the spinal cord. We are having certain types of fibers that are going upward and coming downward, right? So we are having this one. This is the dorsal. This is the dorsal part. This is the anterior, and this one is the lateral part. Okay, so the fibers which are coming downwards from the brain, they are coming from the lateral and anterior part itself, but the fibers, the information that is going, it is going via three pathway. One is lateral, another one is dorsal, another one is anterior pathway. Okay, तीन जगह से information ऊपर जाएगा, दो जगह से नीचे आएगा. Clear है यहाँ तक? Now second thing, ascending tracts में क्या क्या होगा? इसको बोलते हैं spinothalamic tract. Spine से information, the information is going through spine to the thalamus. There will be ventro-posterolateral nucleus. It will be going to thalamus, then it will be going to your cortex. Okay, so we are having anterior spinothalamic tract, we are having lateral spinothalamic tract, we are having dorsal also, right? These are your ascending tract. That means information is going upward. We are having two nucleus. One is fasciculus gracilis, and second one is your cuneatus. Okay, these are the two things. Okay, next what will happen? Try to look here. What will happen here? We are having spinothalamic tract. One is lateral. Lateral will be okay. Lateral will be for the pain and temperature. लात पड़ेगी तो दर्द होगा, right? Anterior is for the light touch or crude touch or pressure. Gracilis फाइन टच, proprioception, ये पूरा डोर्सल वाला जो है proprioception plus 2-point discrimination. Okay, and this is spinocerebellar is always concerned with the movement and position. Okay, cerebellum is always concerned with the movement and position. Okay, next one, try to answer this. Pacemaker controlling the rate of respiration. What is the pacemaker that is controlling the rate of respiration? What is the pacemaker of respiratory system? The pacemaker of respiratory system is pre-Boltzinger complex. Okay, pre-Boltzinger complex. The pacemaker of heart is SA node. The pacemaker of GIT is interstitial cells of Gall. Okay, interstitial cells of Gall. Pacemaker क्यों बोलते हैं? Because they are having, I told you, they are having restless membrane potential. all the pacemaker will be having restless membrane potential, that is -60 to -40 millivolts, right? Next thing, try to look here. We are having respiratory center present in your brainstem, right? That is your pons, and this one is your medulla. In pons we are having pneumotaxic center, we are also having apneustic center. Okay, pneumotaxic, apneustic center, this is your pons. Then we are having this thing, this small thing which is present on the ventral respiratory group. These are ventral respiratory group, this is dorsal respiratory group. dorsal मतलब पीछे है, वेंट्रल मतलब आगे. तो वीआरजी के ऊपर एक छोटी सी स्ट्रक्चर होती है, दैट इज नॉन एज योर प्री बॉर्डजिंगर कॉम्प्लेक्स, एंड दैट इज द पेस मेकर रेस्पॉन्सिबल फॉर जनरेशन ऑफ इम्पल्सेस, राइट? न्यूमोटेक्सिक सेंटर, एपन्यूस्टिक सेंटर, इनका फंक्शन बताता हूँ. व्हाट इज द फंक्शन? सो जस्ट रिमेंबर द फंक्शन. प्री बॉर्डजिंगर कॉम्प्लेक्स इज द पेस मेकर. न्यूमोटेक्सिक सेंटर लिमिट्स द इंस्पिरेशन, whereas apnea में क्या होगा? We need more gases, right? So that would be prolonging the inspiration. इसमें gases ज़्यादा आएंगे. You must have seen the, अपन स्नेक पढ़ते हैं एफएमटी के अंदर, यू हैव स्टडीड अबाउट द स्नेक्स. सम स्नेक्स आर हैविंग न्यूमोटैक्सिक venoms, right? So what it will do, it will block your pneumotaxic center, and what will happen? You will not be able to inspire, you will be having respiratory paralysis, and the patient will die, right? So this is how these snakes are working, right? We are having dorsal respiratory group, we are having ventral respiratory group. If you guys are feeling I'm going too fast, you can tell me. I'm just trying to complete, right? So we are having DRG, we are having VRG. DRG, that is generating the ramp signal, that is increasing the smooth rise in the tidal volume during inspiration. VRG is responsible for forceful expiration during exercise. Okay, just like that we are doing, that is the thing, right? Now try to solve this question. That is the factual information you have to remember. Now in the given spirometry diagram, identify the point B. So what is point B? Try to identify. So how you can identify this? How you can identify this? Is it fine, guys? Okay. So in question number 26, in the given spirometry diagram, identify the point B. What is that? FRC, TLC, VC. So let's try to understand what is the normal thing we are having. Okay, we are having this particular thing that is known as tidal volume, that is 500 ml. Then the patient is trying to expire. That maximally, that is known as expiratory reserve volume. When he is inspiring maximally along with the tidal volume, that is known as inspiratory reserve volume. Okay, and lastly we are having some volume which we cannot touch, that is known as residual volume. Residual volume को कुछ ना कुछ amount of air is always there that we cannot expire, right? So that is your residual volume. Okay, this is how we have to remember all these things, right? I can give you a mnemonic. You can write down, that is your RETI, RETI, TVI. Okay, so these are the volumes, all these are the volumes. You can look here, these are the volumes here, and on the right side we are having the capacities. Okay, so look here, reserve volume, expiratory reserve volume, both of them will be making what? FRC. Both of them will be making FRC. Apart from that, everything is easy. Okay, these are your total lung capacity, this is your vital capacity, this is your inspiratory capacity. Okay, so what is inspiratory capacity? You just need to add these two things. These two things will be tidal volume and inspiratory reserve volume. When you combine these two things, it will become what? Inspiratory capacity. Okay, when you combine all these three things, it will become vital capacity, and when you combine all these four things, it will become total lung capacity. This is what we have written over here. Okay, you can check it later. So I will be sending you the PDF, you can check it later, so you can make it for yourself for solving the questions, right? So this is how we can identify, right? Next question is addition of PUFA in plasma membrane causes. Addition of PUFA in plasma membrane causes. PUFA का मतलब क्या होता है? वी आर हैविंग पोली अनसेचुरेटेड फैटी एसिड। PUFA का मतलब poly unsaturated fatty acid. We are having saturated fatty acids, guys. We are having unsaturated fatty acids. Saturated मतलब क्या होगा? Here it will be having only single bond. Single bond. So single bond होगा तो easily digest हो जाएगा. Not good for health, right? Unsaturated will be having double bonds, triple bonds. So we need more energy to break it down, right? So these are the important ones. Unsaturated, we are having mono unsaturated fatty acid. We are also having polyunsaturated fatty acids. Okay, so कौन से ज़्यादा अच्छे होते हैं? मोनो और पॉली. Basically we are having unsaturated and they are good. Polyunsaturated, the examples are linoleic, linolenic, linoleic acid, linolenic acid. Okay, saturated we are having palmitic acid. Those fried food that we are eating outside, जो fried food हम लोग खाते हैं, that is your basically palmitic acid. Okay, palmitic acid or saturated fatty acid, not good for health. Okay, so this one is better. Linoleic or linolenic is the better one. Okay, so what it will do, it will increase the fluidity of the membrane. Just try to understand the meaning of fluidity is what. फ्लूइडिटी का मतलब क्या होता है? फ्लूइडिटी का मतलब होता है स्ट्रेचेबिलिटी ऑफ द मेम्ब्रेन. फ्लूइडिटी मतलब स्ट्रेचेबिलिटी ऑफ द मेम्ब्रेन, मतलब जो सेल मेम्ब्रेन है वो कितनी ज़्यादा लूज है, कितनी अच्छी है. सो हाउ वी कैन आइडेंटिफाई? वी कैन यूज पूफा. पूफा विल बी इंक्रीजिंग द फ्लूइडिटी ऑफ द मेम्ब्रेन, राइट? Next question. A patient comes to OPD with the complaints of paresis and numbness after sleeping on his arm. So basically this is a case of Saturday this is a case of Saturday night palsy. Saturday night palsy. And for this type of things we are using a classification. This type of question very easy. Okay, so how we are identifying them? With the help of a classification that is known as Erlanger Gasser classification. Okay, चार चीज याद रखनी है. First thing, you have to remember this mnemonic. Mnemonic is Prime Minister pressurized to sign the contract fast. Okay, sign the contract fast. So first thing that I want you to remember, जितना ज़्यादा diameter होगा, the more the diameter, the more will be conduction, because there will be more myelination. There will be more myelination, more diameter, more conduction. Simple thing, fast होगा. More myelination leading to fast. Okay, जितना ज़्यादा न्यूरॉन मोटा होगा उतना ही फास्ट काम करेगा. नेक्स्ट थिंग, we are having A alpha, A beta, A gamma, A delta, B or C fiber. We are having this list of these fibers. So अभी याद कर लेते हैं what are their function and how about the speed and all those things. Okay, so look here, this is having the biggest diameter. That means it will be having the maximum speed. It will be the fastest. Okay, just remember what I'm telling you. Okay, prime minister, it is responsible for proprioception plus motor function. They should be fast, right? Second one is your A beta. It is responsible for pressure and touch. It is responsible for pressure and touch. As for A gamma is for spindle muscle, spindle is there. And A delta is responsible for touch, cold temperature. This was the question they have asked you, cold temperature. And fast pain also known as first pain. This is also they have asked, first pain or fast pain. मतलब जो for example you are going for tetanus injection. Okay, tetanus injection में क्या होता है? First time the needle is pricking your body, that time the pain you are having, that is due to A delta fiber. Okay, but there is another pain that is known as slow pain. Slow pain क्या होता है? टिटनेस के इंजेक्शन के बाद में दर्द होता है, राइट? सो वट एवर पेन इज देयर इन द नाइट इट सेल्फ, दैट इज योर स्लो पेन. दैट इज नॉन एज स्लो पेन. ओके, एंड स्लो पेन इज ड्यू टू सी फाइबर. इट इज ड्यू टू सी फाइबर, क्योंकि ये कैसे होता है? डायमीटर कम है, कंडक्शन वेलोसिटी कम है. सो and B are the fibers that are utilized for autonomic nervous system. Simple question they will ask you from this particular table. They will ask you the fiber which is responsible for proprioception. Your answer will be A alpha. The fiber which is having the maximum conduction velocity, your answer will be A alpha. The fiber responsible for fast pain, your answer will be A delta. The fiber responsible for slow pain, your answer will be C fiber. So this type of question they will ask you from this particular table, right? Apart from that, they will ask you about the pressure susceptibility to that question that we are doing. They will talk about the susceptibility to pressure and hypoxia. Okay, so for pressure we are having A fiber more susceptible as compared to B and C, and hypoxia B are more susceptible than A and then C. You have to remember this sequence. Okay, For local anesthesia also ABC is there, but in anesthesia we are having different things. Okay, so depend on the question we have to mark the answer. Okay, that would be just like ABC. Okay, next question, umami test is evoked by, umami test. Okay, so just try to rule out the option. Glucose will be sweet in nature, so it will be responsible for sweet test. Glutamic acid, I don't know. Okay, acid, for example, I don't know. Okay, next one is your quinine. Quinine is kadwa, right? So that would be for bitter test, bitter. And sodium chloride. Sodium chloride is khara. That is your sour, right? We are having sweet, salt, sour, or bitter. Sorry, that is salt. That is your salt, right? And glutamic acid. Glutamic acid is due to, we are having monosodium glutamate, and that would be responsible for giving this new test, that is umami test. We are having five tests now. We are having five tests now. Okay, sweet, salt, sour, bitter, and umami. And umami is due to this glutamic acid, and this glutamic acid is present in Ajinomoto. Ajinomoto that we are using, it will be having this glutamic acid test, and it is very addictive, right? It is very addictive. So how this information is going to your brain? So we are having, just remember, five. Which nerves are involved? Seven. Then we are having ninth, and then we are having 10th nerve. Five is for general sensation. You must have studied in anatomy. Five is for general sensation. Seventh is for taste. Ninth and 10th, and they will be going to a particular nucleus, that is nucleus tractus solitarius. That is ninth, 10th, and 7th, you can remember like that. So nucleus tractus solitarius is there, and from that the information will be going to your thalamus, and from thalamus the information will be going to your insula, that is gustatory cortex, telling us about the information, right? What are the tastes that we are having? Okay. Okay, yes, spatial sensations. Yes, you can call it spatial sensations also. Okay, you can call it spatial sensation, that is test. Okay, next one is your incretin causes what? What are incretins and what they are causing? Incretin. So just try to understand. Are you guys hungry? Do you want to eat something? Do let me know. I will send it for you. Do let me know, guys. Okay. So for now, I just want to have, like, what do you want to have? For example, you want to have momos, right? Some people wants to have momos. So try to understand what will happen with the momos. When you are eating momos, those momos will be going to your stomach, then they are going to your GIT. In your stomach they will be going to your duodenum. In duodenum what will happen, guys? In duodenum it will be getting absorbed in the form of glucose. Okay, ये glucose आ गया. Now what will happen, this glucose is in the blood now. This is your blood vessel is going, this blood vessel will be having these glucose molecules. This is your blood vessel. So just try to understand the story. I am telling you complete diabetes story. Okay, you will be understanding complete diabetes along with the treatment in the next 10 minutes, guys. Okay, be with me for the next 10 minutes and you will be understanding how it is happening. Okay, my dear doctors, please try to understand this. Okay, look here, we are eating momos. What will happen, sir? After eating momos, it will be ultimately converting digestion, ultimately converting into glucose. Now this glucose is going into blood. It will be absorbed in the blood from your GIT. It will be absorbed in the blood. Now if the glucose is in the blood, we call it hyper. Hyper means zyada, glyce means glucose, emia means in the blood. So what is happening? Hyperglycemia is happening, right? Now this blood vessel is running here and there, and this blood vessel is going to a cell which is present in your pancreas. Pancreas will be having which cells? Pancreas will be having alpha, beta, and delta. Okay, alpha will be glucagon, beta will be insulin. So this is your insulin, this is your beta cells. Just try to understand, forgot my diagrams. Okay, so this is your beta cell. Beta cell will be having which glut? Beta cell is 2, so it will be having glut 2. Beta is 2, so that it will be having glut 2. Now what will happen? Glucose is coming inside. Okay, glucose is coming inside via glut 2. Now glut 2 is a facilitated diffusion, no need of energy, guys. Okay, now this glucose will be converting into ATP, and how many ATPs are formed? 7 ATPs. In glycolysis, how many ATPs are formed? 7 ATPs. Okay, and what is the end product? That is your pyruvate. यहाँ तक तो pyruvate ही होगा, right? I'm not talking about ETC and all. Okay, now what will happen? This ATP is formed, right? Here we are having ATP sensitive. Give your complete attention, guys. We are having ATP sensitive potassium channels. I told you always potassium is leaking out from a cell, maintaining the RMP, right? Now what is happening? This potassium is going out, but this channel is ATP sensitive. That means whenever the ATP is coming, this channel will get blocked. Now if this channel is getting blocked, what is happening? This positive charge is accumulating inside, and I have already told you, whenever there is a positive charge is accumulating inside, that is known as depolarization. इसको depolarization बोल देंगे. Because of depolarization, what will happen, sir? Calcium will come inside. Calcium will come inside. Now utilize whatever information you are having. We have studied about exocytosis, right? Calcium has three functions: constriction, contraction, and exocytosis. Okay, so whenever the calcium will coming inside, what will happen? This insulin will be going outside. So what is happening, sir? Insulin is coming outside in the blood. I have already told you insulin is coming outside in the blood because it is an endocrine gland, right? Insulin will be going into the blood. Endocrine will secrete their substances into the blood. So now what is happening, sir? Earlier we are having glucose in the blood. Now we are also having insulin and glucose together in the blood. Now what to do? Now nothing is happening, right? So just try to understand this. Now what will happen? Now we are having insulin. Are you guys understanding? We are having glucose together. Now this blood will be traveling throughout the body. Now this blood will be going to a special cells. These are having GLUT4. These are having GLUT4 receptor, and these are known as adipocytes. These are known as adipocytes or skeletal muscle. Adipocytes or skeletal muscle will be having which GLUT? GLUT4. GLUT means no energy required. No energy required, right? So these are the glucose molecules. They are already traveling from the body. पहले भी घूम रहे थे, अभी भी घूम रहे. But what is the difference, sir? Difference is this insulin. This insulin will be acting as a key. ये insulin क्या है? ये चाबी है. This insulin is the key, and now what it is doing? It is opening this door. Now what it is doing? It is opening this door, and now what is happening? This glucose will be going inside. Whatever glucose is there in your body, that will be going inside these cells. Skeletal muscle में गया, energy utilization, it will be utilized. Second, adipocytes. एडिपोसाइट्स में ग्लूकोज जाएगा. 3 ग्लूकोज के मोलिक्यूल जुड़ेंगे तो क्या बोलते हैं? ट्राइग्लिसराइड. ट्राइग्लिसराइड के साथ में अगर अल्कोहल जुड़ जाएगा, ट्राइग्लिसराइड प्लस अल्कोहल, triglyceride ultimately making what? Fatty acid. And when it will be binding with the alcohol, what it will make? It will make fats. It will be making fats. So what will happen? Extra glucose will be making fats, and whatever is there, that can be utilized. Okay, so normal कहानी समझ में आई? whatever glucose you are eating, whatever मोमोज वगैरह जो कुछ भी खा रहे हो, जितना ज़्यादा कार्ब खाओगे क्या होगा? उतना ज़्यादा मोटे हो जाओगे. समझ में आ गया यहाँ पर? ठीक है. अभी क्या होगा? ये जो मोमोज खाया है, इसके साथ में क्या हुआ ये समझ में आ गया. नाउ लेट्स टॉक अबाउट व्हाट इज डायबिटीज. ओके, इंसुलिन इज द की. Did you understand? If you are having any doubts, do let me know now itself, right? Now what is happening? Try to look here. Okay, now what is happening? We are having two types of diabetes. Type 1, we are having type 2. Okay, 1 में क्या होगा और 2 में क्या होगा? 1 just like a I. ओके, इसको आई बना दो. दैट मीन्स इंसुलिन डिपेंडेंट डायबिटीज मेलाइटस, बीटा सेल नॉट वर्किंग. बीटा सेल इज नॉट वर्किंग. इफ बीटा सेल इज नॉट वर्किंग, व्हाट विल हैपन? इंसुलिन बना पाओगे? नहीं. इफ दिस सेल इज नॉट वर्किंग, वी नीड टू गिव इंसुलिन फ्रॉम आउटसाइड. द ड्रग ऑफ चॉइस फॉर टाइप 1 विल बी इंसुलिन फ्रॉम आउटसाइड. ओके, टाइप 2 व्हाट इज हैपनिंग? जस्ट मेक अ लाइन हियर. ये क्या बन गया? आर बन गया. सो दैट इज रेजिस्टेंस. Type 2 will be resistance type of diabetes. Now what is happening? Try to look here. In type 2 there is resistance. Resistance to what? Sir, we have the key but we are not able to open this GLUT4. ओके, चाबी खराब हो गई. अभी चाबी खराब हो गई तो क्या करोगे? ताला खराब हो गया, चाबी खराब हो गई. व्हाट यू विल डू? यू विल बी पुटिंग सम ऑयल. तेल डालोगे. ठीक है. सो व्हाट विल बी हैपनिंग? तेल लगाने से क्या होगा, दिस वन विल बी ओपनिंग, एंड व्हाट इज द ऑयल दैट यू आर यूजिंग, दैट इज योर metformin. So drug of choice for type 2 diabetes mellitus will be metformin. अब तुम इसको कहीं भी लगा लो. For example, we are having PCOD or PCOS. PCOD PCOS में क्या होता है, basically there are follicles but due to due to insulin resistance these follicles will not get up the glucose, और glucose नहीं आएगा तो follicle grow नहीं करेगा, that would be giving you certain appearance. Okay, ये appearances आती है. Under drug of choice what we will be doing, we need to reverse the insulin resistance, exercise करवाना है, insulin resistance को reverse करना है, that means we need to give the metformin. Did you understand, guys? Okay, so metformin is the drug of choice for both the scenarios. Okay, now the important thing, what are the other drugs that you are always studying? दो तो अपन ने पढ़ लिए, metformin पढ़ लिया, insulin पढ़ लिया. Now एक there is a group of drug that is your sulfonylureas जो आप लोग पढ़ते हो, that is your G plus side वाली दवाइयाँ, G plus side, that is gliclazide, glibenclamide, glipizide, glimepiride, whatever drugs that you are studying, chlorpromamide, all those drugs will be blocking what, this channel. इसको बंद कर दिया, पोटेशियम चैनल को बंद कर दिया. अगर पोटेशियम चैनल बंद हो गया तो क्या होगा, पोटेशियम एक्यूमुलेशन होगा, पोटेशियम एक्यूमुलेशन की वजह से कैल्शियम आएगा, कैल्शियम की वजह से इंसुलिन बाहर जाएगा, और जब भी इंसुलिन बाहर जाएगा, इंसुलिन इज अ की, राइट, इट विल बी लीडिंग टू whatever hypoglycemia hyperglycemia is there, इंसुलिन बाहर जाएगा तो क्या करेगा, नॉर्मोग्लाइसीमिया कर देगा. ये जो जितना भी ज़्यादा ग्लूकोज है इसको ब्लड फोर खोल के, ताला खोल के अंदर डाल देगा, राइट. सो इंसुलिन का फंक्शन क्या हो गया, ग्लूकोज को कम करना, राइट. नाउ sulfonylureas you have seen where they are working, all these your G plus side drugs, okay, gliclazide, glibenclamide, all these drugs will be working there. Now we are having one more group of drugs, that is your incretin. Okay, यहाँ पर एक चीज़ होती है GLP-1, try to understand this, समझो इसको. We are having GLP-1, GLP-1 is a, it is a incretin. ठीक है, इंक्रेटिन का फंक्शन होता है, इट विल बेसिकली रेगुलेट द रिलीज ऑफ शुगर. ओके, सो दिस GLP-1 इज ब्रोकन डाउन विद द हेल्प ऑफ एन एंजाइम दैट इज DPP-4. ओके, तो मुझे क्या करना है, वी नीड टू इंक्रीज दिस, वी कैन गिव अ ड्रग दैट इज GLP-1 एगोनिस्ट, और आई नीड टू ब्लॉक दिस. टू ड्रग्स वी कैन यूज. सो GLP-1 वाली दवाइयाँ, दीज आर योर ग्लूटाइड, टेडुग्लूटाइड, लीराग्लूटाइड, सीमाग्लूटाइड. ओके, whatever glutide you are having. DPP-4 is your gliptins. DPP-4 is your gliptins. Whatever gliptins you are having, sitagliptin, linagliptin, vildagliptin, whatever gliptins you are having is your DPP-4 inhibitor. Apart from that, 2 or 3 drugs are left. I would be completing them. That is your whatever momos you are eating. Now this momos needs to convert into glucose, and for that we are having an enzyme that is alpha glucosidase. ठीक है, इसका काम क्या होता है, इसको तोड़ना, right. So what I can do, I can block this enzyme. So what will happen, momos will directly, just suppose we are eating sucrose, so it will be going directly into the feces, right. So that is how we can use these drugs, that is your acarbose, miglytol. You can read those drugs in great details in your pharmacology, just for the understanding purpose I am giving you, right. In case side effects honge, because it will be causing flatulence, all those things, right. It will be causing gliptins, pancreas, they will be causing pancreatitis. Okay, teduglutide is the GLP-2 agonist. One more information from surgery, for dumping syndrome, or short bowel syndrome, those people, we are cutting their stomach, like duodenojejunostomy we are doing, those people we are giving GLP-2 agonist drugs like teduglutide. Okay, teduglutide क्या करेगा, डिले करेगा gastric emptying को, it will be delaying your gastric emptying so that your food will get absorbed better, right. So these are the drugs, and apart from that, one more is left, that is your SGLT2 inhibitors, and your glitazones. Okay, that is your rosiglitazone and pioglitazone. Then we are done. Rosiglitazone and pioglitazone, basically they are cardiotoxic drug, we don't use, but their mode of action, they are activating PPAR gamma. One more drug that is activating PPAR gamma is that is your telmisartan. This is important question. Telmisartan is important question. Those patients who are having diabetes, telmisartan is having a activity of PPR gamma activator. Okay, so we can use that. So this is your SGLT2. This is present in your PCT and responsible for 100% absorption of glucose. 100% absorption of glucose. So PCT जितना भी ग्लूकोज जाएगा सारा एब्जॉर्ब हो जाएगा, राइट. But there are certain cases when the glucose is more than 180 mg deciliter in the blood. What will happen? It will start to have glycosuria. This is the normal functioning. Now when we are giving SGLT2 inhibitor, what will happen? सारा ग्लूकोज जो 100% absorb हो रहा था, it will not get absorbed. It will be going into urine, and that would be causing glycosuria, and there will be bacterial infections, and because of that bacterial infection, patient will be having UTI, fever, all those things, right? I think we are going too much in details. Let's come to next topic. If you are having any doubts, you can ask me. You can even ask me later also. Okay. We will be meeting tomorrow as well, right? Next one is your parathormone. Parathormone has all of the following effect except. पैराथार्मोन में क्या क्या होगा एक्सेप्ट. सो फर्स्ट ट्राई टू अंडरस्टैंड पैराथार्मोन का फंक्शन क्या होता है. ओके, वी आर हैविंग दिस पैराथायरॉयड ग्लैंड, कैल्सिट्रायोल एंड कैल्सिटोनिन. बेसिकली पैराथार्मोन, PTH is coming from which gland? PTH is coming from which gland? Yes, acarbose, viglitol, voglibose, all those drugs, guys. Try to answer. Let me teach you one more important concept for physiology. You must have already studied about like that is your after menopause. You know what happens? There will be osteoporosis. After menopause there is osteoporosis. Why it is happening? This is also related to this particular thing. So look here, we are having parathyroid hormone, guys. Parathyroid hormone करेगा क्या? It will be working on osteoblast. It will be working on osteoblast. Remember, इसका function होता है, it will be breaking the bone. It will be breaking the bone. That is the normal function, and that is the very very important question they can ask you. The function is breaking the bone. Bone is made up of calcium pyrophosphate. Calcium और phosphate की बनी है bone. So basically, it will be breaking the bone and increasing the calcium and phosphate. That is the normal functioning. But the first question that is important, it will be activating osteoblast. इसको करना किसको एक्टिवेट चाहिए था? osteoclast को, but it is activating osteoblast. Now what is happening? This osteoblast will be activating rank ligand. Let's see. It will be activating rank ligand, and your rank ligand will be activating osteoclast. Your rank ligand will be activating osteoclast, and osteoclast will be causing what? Calcium and phosphate release. Okay, calcium and phosphate release. Now comes the most important part, that is estrogen. E2 वाला estrogen जो होगा, it will be making a thing that is known as osteoproteogenin. Okay, there is a thing that is osteoproteogenin, and the function of osteoproteogenin is to inhibit the rank ligand. जब तक osteoproteogenin है, okay, जब तक osteoproteogenin है तब तक rank ligand inhibit रहेगा. Okay, and osteoproteogenin is under the control of E2. estrogen जब तक body के अंदर है तब तक osteoproteogenin will be working until the time rank ligand will be inhibited. And if rank ligand is inhibited, osteoclast will be inhibited. There will be no resorption of bones. Now what is happening? Sir, there is no estrogen. That means there is menopause. Menopause. Now what is happening? If there is menopause, is there any possibility this will be activated? No, this will not be activated. This brake will be lost. And now what will happen? This rank ligand will get activated, and this one will be breaking the bones and leading to release of calcium and phosphate. This is how the osteoporosis is happening. Okay, you understand? Now the function of parathyroid hormone, try to understand. This is the basic thing. We are using multiple drugs we are using. Okay, we will discuss some other times. Just try to connect from here itself, right? So we are having parathyroid hormone. What is the stimulus for parathyroid hormone? So whenever there is decrease in the serum calcium function, I have told you, it will be breaking the bones. It will be increasing serum calcium and phosphate also. Okay, second function, it will be increasing serum phosphate. It will be increasing serum phosphate, sorry, what is the first function? First function will be decrease in serum calcium. Second thing is increase in serum phosphate. This is important, guys. Whenever there is increase in serum phosphate, I will be telling you how there will be release of parathyroid hormone. Third thing will be decrease in serum calcitriol. Calcitriol is nothing but your vitamin D3. Whenever D3 is decreased, whenever there is calcium decrease and phosphate increase, parathyroid hormone will come. It is situated behind the thyroid gland. Okay. Now what will happen? It will be going to bones. Bone में क्या करेगा? It will be causing resorption of the bone. It will be breaking the bone, ultimately releasing phosphate and calcium. Okay, second thing, it will be going to kidney. It will be causing increase in calcium resorption. Calcium को reabsorb करेगा, but the most important thing is it will be causing release of phosphate. Okay, so ये क्या कराता है? This is a nasty thing. This is causing phosphate urea. Okay, this one is letting the phosphate go out from the urine. TRPV5 pump हमने पढ़ा था. From the DCT, it will be letting the phosphate go out from the body and it will be absorbing calcium. Okay, in intestine, what it will be doing? It will be increasing calcium absorption in the intestine. Okay, ultimate effect क्या होगा? Ultimate effect will be, it will be increasing the serum calcium and decreasing the serum phosphate. Okay, second one is your calcitriol, that is also known as vitamin D3. Vitamin D3, what will be the function of vitamin D3, guys? Whenever there is decrease in the calcium कम हो गया बॉडी के अंदर, विटामिन D3 विल बी रिलीज. फॉस्फेट कम हो गया, विटामिन D3 विल बी रिलीज. पैराथायरॉयड हार्मोन बढ़ गए, विटामिन D3 विल बी रिलीज. हियर वी हैव सीन द पैराथायरॉयड इंक्रीज will lead to calcium, will lead to vitamin D3 absorption. Okay, what are the things that it will do? It will increase the resorption of bone. Second thing, it will be increasing the calcium and phosphate reabsorption. Vitamin D सबको absorb करेगा. Third thing, it will be increasing calcium and phosphate reabsorption. Ultimately ये बढ़िया है. What it will do? It will reabsorb the phosphate. It will increase the calcium also. ये दोनों का reabsorption कराएगा. But this one is releasing the phosphate only. Okay. Next one is your calcitonin. Calcitonin के बारे में क्या याद रखना है? जब भी सीरम कैल्शियम बढ़ेगा, then only this calcitonin will be released, and it is released from parafollicular cells. We have seen parafollicular C cells that are present in thyroid gland. Okay, so वहाँ से निकलेगा. What it will do? It will decrease the resorption of the bone. First thing, it is beneficial, so it will be decreasing the resorption of bone. Second thing, it will increase the calcium and phosphate excretion. Okay, so ultimately what it will do? Ultimately sir, it will be decreasing the serum calcium. मतलब ब्लड के अंदर कैल्शियम कम कर देगा, बोन के अंदर ये बेनिफिशियल है. बोन के अंदर कैल्शियम बढ़ा देगा और ब्लड के अंदर कैल्शियम कम कर देगा. That is the simple function of calcitonin. Did you understand? Okay, just see it once again and you will be understanding this simple things, right? Catabolism of H2O2 is carried out by which organelle? Try to answer this. Catabolism of H2O2 is carried out by which organelle? So that is carried out by peroxisomes. Peroxisomes will be converting H2O2 into H2O plus O2 with the help of an enzyme that is catalase. Tomorrow we will study about catalase positive organisms. So catalase में क्या होगा? Oxygen is going out, so they will be giving some kind of a bubbles, right? Bubbly appearance, right? So peroxisomes, the function of peroxisomes will be damage of free radicals को मारेगा. And two important question they have asked, two diseases. First one is your Refsum disease and second one is your Zellweger syndrome. Two diseases are associated with this peroxisomes. If there is paroxysmal disorder, there can be two diseases. One is Refsum disease, second one is your Zellweger syndrome, right? Next one is your endoplasmic reticulum. The function of endoplasmic reticulum will be protein synthesis. Okay, and the lysosome function will be, lysosomes का function क्या होगा? Autophagy. Okay, and the function of mitochondria, the most important, it will be causing beta oxidation of fatty acids. All your Krebs cycle, TCA cycle, all these things will be happening in the mitochondria. Okay, Krebs cycle, TCA cycle, all these things will be happening in the mitochondria. Apoptosis. Okay, apoptosis is also happening in the mitochondria, right? So the answer will be A. Next question. In the cystometrogram, 1B indicates what? This is a NEET PG question. In the cystometrogram, 1b indicates what? And that is the that is plasticity, guys. That is the plasticity, okay? And this 1b is indicating about a law that is known as Laplace law. Basically, what is happening? Cystometrogram. So basically, this is the bladder condition. What is happening in the bladder? So earlier, what will happen? There will be accumulation of some urine. Then what will happen? After some time, there will be a plateau phase, and then what will happen? There will be a constant urge. You need to go. Okay, this is the point. After that, you need to go to urination. That would be approximately 400 ml, right? Here you will be accumulating, you will be having the first urge, and this is the part where what is happening, the volume will be increasing. This is the volume will be increasing, but the pressure will be normal. This is the point, right? So this is the part 1b, which is indicating about the Laplace law, and this is based on the plasticity. Okay, collecting duct has which cells, guys? Try to answer this one. Collecting duct has which cells? Try to answer this one. Collecting cells will be having what, guys? Try to answer. Remember, I've told you collecting duct in the kidney will be having two types of cells. In the upper part, we are having principal cells, principal and intercalated cells. So basically, these are the cells for sodium channels, right? These are basically epithelial sodium channels. This is also known as ENaC channel. Okay, intercalated are two cells. We are having potassium, we are having for H plus, renal outer medullary potassium channel from K, and we are also having this. And here on the basolateral side, we are having aldosterone. Aldosterone will be function to make ENaC channel. ENaC से क्या होगा? Sodium will be coming inside, and sodium के अंदर आने की वजह से what will happen? Potassium will be going outside. Okay, so this is the principal and intercalated cells. Okay, parietal oxyntic we have seen in the GIT. Podocytes you will be finding in the kidney. JG cells will be releasing what, sir? Renin. Okay, JG cells will be releasing renin. Aldosterone is coming from where? Aldosterone is coming from which part of the which part of the adrenal gland? We are having cortex, we are having medulla. We are having cortex, we are having medulla. In cortex, we are having three layers, that is GFR: glomerulosa, fasciculata, reticularis. This is your adrenal gland. Okay, adrenal gland will be having two parts, cortex and medulla. Glomerulosa will be releasing mineralocorticoid. Remember, salt, sweet, and sex. So we are having mineralocorticoid, that is aldosterone. Fasciculata will be releasing your cortisol, all your steroids. Okay, and reticularis will be releasing your DHEAs. Okay, medulla will be releasing epinephrine, norepinephrine, and dopamine. These are collectively known as catecholamines. They are collectively known as catecholamines. Okay, they are collectively known as catecholamines. Mutation of which of the following will lead to paroxysmal nocturnal hematuria? Try to answer this one. Mutation of which of the following will lead to paroxysmal nocturnal hematuria, guys? Easy questions in the last. So, if there is mutation of spectrin, there will be a disease known as hereditary elliptocytosis. If there is mutation of ankyrin, there will be a disease known as hereditary spherocytosis. And DAF and MRIL mutation. DAF is CD55 and MRIL is CD59. They are the other name of CD55 and CD59, and they are concerned with the disease that is known as paroxysmal nocturnal hemoglobinuria, paroxysmal nocturnal hematuria. Okay, and this is your myelin basic protein. Myelin basic protein is always concerned with the formation of myelin sheath. Okay, myelin sheath, I have told you, the more myelin will be there, the more conduction will be there, the more velocity will be there, the more diameter will be there, right? So we are having this myelin basic protein, and its function is formation of myelin. If this protein is lost, what is the disease that can occur? That is your Try to answer. That is your multiple sclerosis, guys. Multiple sclerosis is a demyelinating disorder, right? Demyelinating disorder. Okay, this is about the mutation of which of the following will lead to PNH. Your answer would be DAF and Miril, also known as CD55 or CD59. Okay, try to answer this one. A body fluid sample is being studied and has 10 milliequivalent of sodium. So just write down this type of questions, easy questions. Okay, don't panic. This type of questions, 10 is the sodium. How much is the potassium? 140. Chloride, 4. Identify the fluid compartment. How you can identify? Just try to look here. Sodium, you already know. Potassium is more outside or inside? The potassium is more inside. If the sodium is more, that would be outside situation. So basically where they are talking about extracellularly or intracellular department. Okay, they are basically talking about inside the cell, that is intracellular. Let's see how these things are happening and how they can ask you the question. So this is the graph. We are having different things. First of all, this is extracellular region, this is intracellular. Cell के बाहर का, that is extra, ये intracellular. Extra में क्या होगा? First of all, let's look at the level of sodium. Sodium is 140. So they will ask you the question, what is the most abundant extracellular cation? Most abundant extracellular cation. Your answer would be sodium, because this is a cation. Cation is a positive charge, anion is a negative charge. Okay, they are talking about extracellular compartment, this above compartment. Okay, what is the most abundant extracellular cation? Your answer would be sodium. If I ask you the same question, what is the most abundant intracellular cation? Your answer would be potassium. Most abundant intracellular cation, that is also approximately around 140. Then your answer will be potassium. Okay, then your answer will be potassium. If they ask about other things, for example, they ask about anions, most abundant extracellular anion, your answer will be chloride. Most abundant extracellular anion, anions means negative charge, your answer will be chloride. If they ask you about the most abundant intracellular anion, then your answer will be phosphate or inorganic anions, right? So this is how you are going to answer this type of question, and they are very simple. They give you certain values, you just need to check for the values and you will be easily understanding that. Okay, just look at this diagram once, just try to understand how much is what, and this is how you are going to crack this type of question. Okay, now the next question, insulin mediated glucose uptake in skeletal muscle and adipose tissue is occurs due to, I've told you, skeletal muscle and adipose tissue. What is the key that is coming and working? That is your insulin. And what is the GLUT that is present over here? That is your GLUT4. That is GLUT4 is present for adipocyte and skeletal muscle. Okay, skeletal muscle. Try to see how many GLUTs we are having and how do we remember them. Okay, so GLUT number 1 that is present in your brain, kidney and placenta. The most important I would be telling you, that is GLUT number 2 that is present in your pancreatic cells. Apart from that, liver. Okay, GLUT3 not so important, that is also BKP, that is brain, kidney and placenta. No, not so specific. Okay, 1 and 3 are not so specific, but 2 and 4 are very important. 4 will be present in your heart. Second is your skeletal muscle, and third I have already told you, that is your adipocytes. Adipocytes will be having what, sir? GLUT4. And I've already told you in the question number 1, F for 5, F for 5, F for fructose. Okay, so GLUT5 is always concerned with fructose and glucose. Okay, fructose. So in sperm you will be finding that fructose. Okay, SGLT1 is a type of, first question, SGLT1 is a type of primary active transport, secondary active transport, facilitated diffusion. What is that? Try to answer. We are also having SGLT2. SGLT2 is present in PCT. Function I have already told you. Function is absorption of glucose, simple function. Okay, 100% absorption of amino acid and glucose will be there. So that is your SGLT2. Okay, try to answer, guys. This is a question. SGLT1. SGLT1 कहाँ पर होता है? It is present in the intestine. That is the basis we are giving ORS. That is the question they have asked you. In ORS, what is there? Sodium and glucose are given in the equal concentration. Okay, sodium and glucose are given in the equal concentration because they are going through Sodium glucose like transport 1, sodium glucose import are there. Okay, the amount of sodium will be going inside your GIT, the amount of water, amount of glucose will be going same, right? So that is why when you are having diarrhea, the more the amount of water you will drink, nothing will happen. You have to take ORS. ORS will be having what? Sodium and glucose together. Sodium and glucose together, that is 75 they are together, right? 75 sodium, 75 glucose together. So what is happening? The amount of sodium is going inside, the amount of water will be going inside. So basically sodium, the amount of sodium will be going inside. Sodium is a salt, and just remember like that, sodium is just like a beautiful girl, and the boys are following, and the boys are water, right? So whenever the sodium is going inside, the water will always follow. Okay, so what we need to do, we need to give the sodium, and the water will always follow, understand? And now SGLT2 is present in your kidney, PCT, and we have already remembered the drugs, that is your canagliflozin. So when we are blocking this system, what will happen? Gliflozin, canagliflozin, dapagliflozin. So that basically means glucose flows in urine. What will happen in canagliflozin, dapagliflozin? Basically, they are SGLT2 inhibitor. The glucose will be going into urine, and urine will be having urine infection. You can have foreigners gangrene, you can have basic UTI infections. So these things can happen, right? So this is what you need to remember about the glut itself, right? Moving on to next is your two questions left. Try to answer this one. A 55-year-old female patient presented with the history of venous thromboembolism and started on an anticoagulant warfarin. Now, this warfarin will work on secondary hemostasis and decrease the plasma concentration of the which of the following. Okay, so यहाँ पर क्या पूछा है? Basically, they wants to know about the mechanism of action of warfarin. Okay, so basically it will be working on prothrombin. Basically it will be working on prothrombin, but we are having two things. We are having one thing, that is primary hemostasis, and secondly we are having secondary hemostasis. देखो होता क्या है, whenever you are having a cut, you know what happens? There is bleeding. After sometimes, after what is the bleeding time? That is 2 to 9 minutes. After 2 to 9 minutes, what is happening? The bleeding will stop. But some people are like naughty people. What they will do? They will just try to press it. Okay, they will just try to press it, and what will happen? Bleeding will again restart. So first time the bleeding is stopping is due to primary hemostasis, and second time when there is bleeding, after sometimes, after 5 to 6 hours, 10 hours, what will happen? When you try to press the same lesion for the next day, is there any possibility there is bleeding? No, there is no bleeding after next day. So that is secondary hemostasis. Now the coagulation cascade, whatever you are studying about coagulation cascade, that would be coming under secondary hemostasis. In primary hemostasis, we will be studying about the platelets, we will be discussing about von Willebrand factor, GP1B, है ना, GP2, GP1B or 2B, 3A, GP2B, 3A. That is what we are talking about, right? In primary hemostasis. In secondary hemostasis, we will be talking about clotting factors. Okay, clotting factors. Okay, I'm not going into detail. Just remember the names of all these clotting factors. We can do it sometime later, or you can watch the complete videos. Okay, so we are having mnemonic, we are having freshers party tonight, come let's sing and call seniors, please have fun. Or you can also remember Hindi mnemonic, that is face पे तेरे चुनरी लाल, PACS, पैक्स पे हम फिदा. Okay, face पे तेरे चुनरी लाल, पैक्स पे हम फिदा. So this is how you can remember. These are the two mnemonic. Okay, the most important one that you should be knowing is fibrinogen, then your prothrombin, then your this one calcium, and anti-hemophilia A, B, and this one is your 10. These are the most important one, and 13 also. Okay, so these are the most important one that you should be knowing. When we are going to discuss in detail, we can study about that. Okay, next one, concentration of which of the following will be maximally decreased in PCT. Now you have already studied about this. ओके, पीसीटी में किसका कंसंट्रेशन कम हो जाएगा? तो लुक हियर, 65% of sodium, 65% of water, whatever sodium is going, whatever water will follow, right? 65% of potassium, urea, 70% calcium, 80% bicarb, but 100% of glucose and amino acids. Two times asked question है, right? So 100% of glucose and amino acid will be reabsorbed from the kidney. Which part of the kidney, guys? Which part of the kidney? That is your glucose, that is your PCT, that is your PCT. Okay, that is your PCT. Next one, last question. This is, we have already seen what are the different things we have to discuss here. Last question is that pulmonary surfactant is secreted by which of the following cells? Try to answer this one. Pulmonary surfactant is secreted by which of the following cells? Try to answer this one. It is secreted by Nikhil Begadia, Ankit Chaudhary, Dr. Anonymous. Try to answer this one. So basically we are talking about surfactant. Surfactant मतलब क्या होता है? Surface tension antagonist. Okay, surface tension antagonist. So basically we are having alveoli collapse नहीं हो उसको बचाने के लिए, to prevent the collapse of alveoli, we are having this surfactant kind of thing. Okay, surfactant का function क्या होता है? To prevent the collapse of alveoli. Try to answer one. Try to answer, guys. Okay, so when does the production start of this surfactant? Production start on 20th week. Okay, and when it is maximally present, that is your approximately 33 to 34th week, right? But before that, if sometimes there is a premature delivery, okay, there is a preterm delivery of the baby, you know what happens? The baby is coming out and baby do not have surfactant in their lungs, right? Surfactant is basically made up of lipid. It is made up of lipids, and you already know we are giving steroids, and steroids will always increase lipids. Okay, steroids का function क्या होता है? Dexamethasone, beta-methasone that you are giving, basically they will be increasing the lipids. Okay, और lipid बढ़ेगा तो क्या होगा? They are causing hyperlipidemia, so that lipid will be helpful in the production of the surfactant. That is why we are using dexamethasone or beta-methasone, right? Now what is happening when there is a baby who is a premature baby and there is no surfactant, you will be finding this type of structure. This is known as white out lungs. This is known as white out lungs. White out lungs. This type of lungs picture you will also see in ARDS patient. Okay, ARDS patients will also show you this type of picture. Lungs should be black. Okay, air should be black in the lungs. तो lungs कैसे दिखने चाहिए? Generally black दिखने चाहिए. What are the other names of this surfactant? That is your, और क्या क्या नाम है इसके? Try to answer. बस निखिल बस. Every question I think you are marking the answer B. Okay, so we are having palmitoyl dipalmitoyl phosphatidyl. We can also call it dipalmitoyl phosphatidyl choline, DPPC. This is also known as lecithin. This is also known as lecithin. And one important ratio that we are checking for fetal lung maturity, that is lecithin sphingomyelin ratio. Sphingomyelin ratio. Okay, and it should be more than how much, guys? It should be more than 2. It should be more than 2. Lecithin sphingomyelin ratio should be more than 2. That would be telling us about the fetal lung maturity. That would be telling us about the fetal lung maturity. अगर ऐसा बच्चा बाहर आ गया, never ever give the 100% oxygen to any baby. Okay, we need to give, we can use CPAP. We are having different things. Okay, so इसको हम लोग बाहर से क्या दे सकते हैं? हम लोग बाहर से इसको सर्फेक्टेंट दे सकते हैं. We can give the surfactant from intratracheal route. Okay, this baby, we can let this baby survive also. Okay, so we can give this baby the surfactant from outside. So this is what about the thing. Okay, Clara cells, the answer will be yes, everyone, the answer will be 2. That is your type 2 pneumocytes. That is your type 2 pneumocytes. Okay, Kupffer cells कहाँ होते हैं? Kupffer cells are basically monocytes. Monocytes or macrophages. Macrophages in different organ are known as different names. For example, macrophages in liver, we call it Kupffer cells. Macrophages in spleen, we call it Hofbauer cells. Macrophages in brain, we call it mesangial. In kidney. Okay, in brain, microglia, in kidney, mesangial cells. Okay, in skin we call it Langerhans cells. Okay, so basically they are all macrophages, and based on the location we are just identifying it with another names. Okay, for example, in bone we call it osteoclast. So basically they are all macrophages. Okay, with this we are done with the most important topics, guys. Approximately I try to give you the most important information. Okay, so just look at the code. Nobody can go back and restart a new beginning, but anyone can start today and make a new ending. Even if you have not studied physiology, watch this video. I think you will be able to solve most of the questions. I think now you are getting some confidence. If yes, then do let me know in the chat section. These are my Instagram and Telegram handle in case if you want to have any queries and you want to reconnect for any like positive suggestions, anything you want to have, anxiety, because I know right now the exam is coming so near, only 20 days are left for your examination. You must be anxious, so you can always reach out to us. We are always ready for your help. Okay, so without any further delay, let's end the session. Have good food, good night, good sleep, and always remember, it's just like 20 days left for your examination. Try to have good food. Okay, good food, good sleep, because this is what is going to help you in the examination. Okay, you have to take care of your health. That is the most important thing in the last few days I can suggest you. Apart from studies you have to do, but take care of your health. That would be very very important. Okay, मजा आ गया. Thank you. Okay, so PDF you will be getting in Telegram group. I will be sending the PDF here itself. Okay, I will be sending now the PDF, and I will be sharing with other PDFs also. Okay, tomorrow we will be having microbiology session, so please try to do join and try to revise whatever things you can do, right? So tomorrow we will be having the microbio. We will be doing microbiology. Okay, thank you so much for all the patience. Keep learning, guys. See you tomorrow. If you are having any doubts, you can ask me. PDF gang has activated, I know. I will be sending PDF now itself. You can join the Telegram group. I will be sending now. Okay.